Good morning. Morning. Good to see everybody on this beautiful Monday morning in Georgia. Great weather. Nice to be here. Appreciate y'all making this a priority in your day. My name is Katie Dempsey, and it is a privilege to get to start this discussion today and to host each of you here, but also to chair the study committee. We've got some great members, and in just a minute, I'm going to ask them to introduce themselves to you so that you know who is up here. But before we get started, I want to ask Representative Cameron, please, to open us with a word of prayer. 24.
Heavenly Father, thank you for bringing us together on this Monday. We've got a lot to learn and a lot of issues to tackle. Please give us wisdom, patience, and calm to hear all the various people here today and deal with these issues to help these young people who are being left places and to get them places where they're safe and loved and taken care of. We ask this in Jesus' name. Amen.
Thank you so much. So we're gonna try to get the numbers right here. If you would punch your button and yeah, okay. If you'd introduce yourself to the room, please.
Thank you.
So,
Good morning, everyone. Happy to be here. My name is Omari Crawford, and I'm the state rep out of Georgia's 89th House District.
Representative Cameron.
Mike Cameron, I represent House District 1, which is in the far northwest corner of the state. I'm contiguous with Tennessee at Chattanooga, all the way to Sand Mountain, Alabama, all the way to Chattooga County, about 400 square miles. Thank you.
And Chairman Cooper.
I'm Karen Cooper. I represent East Cobb, probably had the closest drive in this morning. And I chair the Public Health and Community Health Committee.
Okay, back to me. Okay. Katie Dempsey, I represent Rome and parts of Floyd County, House District 13, and just care greatly about this. We've also got Amber here with us, who is the real champion of the work we're getting ready to do here. She'll help us pull it all together. But I just I want to share just a little bit with y'all. So this began certainly with a bill that we tried to address and make the issue happen. It brought forward several conversations. And I think last year we began to realize how big, how pervasive, and how much more emphasis and work this probably needed. So my thoughts on this, as we did have the conversation about moving to a study committee, is how surprised most members were that were told about this challenge. And we often think about adults in mental health crisis that get stuck in an emergency room waiting for placement. But I think this really surprised so many people. And understanding our at-risk children, I know each of you that are here today do and are going to help us understand that better. Recent information, I think, that we've all come forward with too, are just some of the unique impacts, not only the ACEs and the trauma that are happening in many children's lives, but also some of our most high achieving, even very wealthy families are dealing with issues that involve a young child. I've heard about some really even as young as 5, dealing with really tough circumstances and understanding why there are those points when anyone feels, I can't do it anymore. Whatever the reason is, not to judge it, but to figure out how we help to be in that child's corner and find them the best place that they can have to recover and to live a meaningful life, because each and every person counts. And I think we have to help these children as well as the caregivers understand that they matter, that they're hurting and lost, and they need to know that they matter. So that's what I hope we'll start our discussion with today. And let me find the great information that Amber gave me. Our first speaker will be Department of Human Services, Audrey Brannon, the Complex Care Coordinator, and Dana H. Carroll, Deputy General Counsel. And Ms. Brandon, I'd love you to share anything else with us that you'd like to about your experience.
Good morning, Chairwoman Dempsey and committee members. My name is Dana Carroll, and I serve as the Deputy General Counsel for the Department of Human Services. Thank you for giving us the opportunity to speak with the committee this morning. I'm joined by my colleague, Audrey Brannon, who will provide examples on what this situation looks like from our Division of Family and Children's Services perspective. But first, I want to give some context on what abandonment truly means. Too often, Georgia parents feel like they cannot adequately parent their children with mental or developmental disabilities, and those children end up in the foster care system. The cause of these abandonment cases is multifaceted, but one clear fact is that DFACS is not the answer for these families. I'll begin by discussing why, from a legal perspective, these children should not be entering foster care. The U.S. Constitution and Georgia law and Georgia Constitution recognize the fundamental rights of parents to direct the upbringing and education of their minor children. In Georgia, parents have a right to physical custody of their child, the right to determine the nature of the care and treatment of the child, including ordinary medical care, the right and duty to provide for their care, protection, training, educational, and the physical, mental, and moral welfare of their children. Parents also have a statutory obligation to their children in that it is the joint and several duty of each parent to provide for the maintenance, protection, and education of their child. Those are referenced in the handout that you have listing Georgia statutes on this subject. In the Juvenile Code, it is clear that the intent of the General Assembly when writing the Juvenile Code was to preserve and strengthen family relationships, countenancing the removal of a child from his or her home only when state intervention is essential to protect the child and enable him or her to live in security and stability. The Juvenile Code establishes that a child should be removed from their home only when necessary to assist and protect children whose physical and mental health and welfare is substantially at risk of harm from abuse, neglect, or exploitation, and who may be further threatened by the conduct of others. Youth who enter DFACS custody due to a parent refusing to allow a child to come home, whether due to a child's behavior or frustrations or our mental health systems, do not meet the statutory requirements of the purpose of the Division of Family and Children's Services to protect children from abuse and neglect. Often these parents do not know what else to do and act upon false assurances that DFACS can provide their child with the treatment they need. And what we've done at that point is take away the parent's right and ability to make treatment decisions for their child and have given that ability to the state. Parents of children being discharged from mental health facilities are understandably concerned and nervous for their child to return home when they have not been involved in the treatment planning for their child, have not received any services or proper discharge planning from facilities. Instead of providing these services essential to a successful return to the community, providers call DFACS and make reports on the basis of abandonment. In the Juvenile Code, abandonment refers to conduct on the part of a parent showing an intent to forego parental duties or relinquish parental claims. You have the entirety of that statute in your handout as well. The parents of children being discharged from facilities do not intend to forego their parental duties or relinquish their parental claims. They feel they have no other options because their children are not receiving the treatment they need and their families are not getting the support they need in order to successfully transition these children back home. These children are not neglected. They are not abused. They do not have a maltreating caregiver. They are caught in a system that does not offer the supports for their families needed to maintain them at home. I'll now turn it over to our complex care coordinator, Audrey Brannon, to give a more detailed account of what we are seeing at DFACS.
Good morning. As Dana said, my name is Audrey Brannon, and I just started my 23rd year with the Division of Human Services and Department of Family and Children's Services. I'm a licensed clinical social worker, and I serve as DFACS's complex care coordinator, so kind of all things mental and behavioral health for kids in foster care. When Commissioner Brose came to the department, In the very first conversation I had with her, I said, "Every day feels like we are fighting a forest fire with a squirt bottle." It had felt that way for years. There were significant changes after the unbundling of treatment services and room board watchful oversight in 2017 and the juvenile code reform in 2014. Those two changes completely altered the foster care system in Georgia. Since that time, there has been a huge reduction in juvenile incarceration, which was the purpose of reform, but those kids didn't disappear. Their problems did not either. For a decade now, those kids have been coming to DFACS, sometimes as CPS cases, Child Protective Services investigations, and sometimes into foster care. It was a forest fire that we were fighting with a squirt bottle. At DFACS, we became so effective with that tiny squirt bottle that folks started saying we should be called to every single fire. In fact, it felt like everyone thought we were the only ones that could fight a fire with our squirt bottle. It is better now. We have some people that are kind of acknowledging that we need a fire hose. They're cheering us on from the sidelines. A few people have even gathered their squirt bottles and are right there with us. Others are faulting us for not putting the fire out quickly enough. In Georgia, foster care is not a voluntary service. It is not meant to meet the mental health needs of a child or protect a family from a child who is a safety risk to the parent and siblings or themselves. But DFACS has become that, and we need help. I want this committee to understand that foster care is not a place. It's a legal custody status. When kids enter foster care from a hospital, they still need a place to go. If they could go to a foster home, they could go to their home with their families, and they can't. We don't have the place for them to go. DFACS does have some places like this, a couple of them, literally a couple. And we have a couple of places for hundreds of kids already in foster care who have experienced horrible abuse and neglect, and they're in desperate need of those beds. And there are literally just a handful of beds, and that's not an exaggeration. It literally feels like the Hunger Games sometimes, trying to get a bed for these kids. Match doesn't have the place for them to go. The hospitals don't have the place for them to go. They think that we do, and that is the problem. We are not withholding resources. They just aren't there. So I want to take a few minutes today to tell you about some of the kids just from this past week that came across my desk. Desperate families, desperate social workers, kids who are desperate and expressing themselves in really tragic ways. I've changed some details, of course, to respect confidentiality and protect their identity. So I'm using some pseudonyms. So Mark, he entered foster care last week. He's 13. His mom is caring for all of his siblings at home. She lives in a 4-bedroom house. She works at a law office. In the spring of 2025, he spent 2 months at a psychiatric residential treatment facility, a PRTF. He was administratively discharged from that facility before he could complete any treatment. Previously, he did over $8,000 worth of property damage at a crisis stabilization unit, or a CSU. That was during one of his 17 times he's been to a CSU just this year. We first became involved in July when at the YMCA, he was so disruptive that the camp had to evacuate to a separate building. Law enforcement, an ambulance, mobile crisis all arrived, and he was taken to a local emergency room for further assessment. It was his second day at summer camp. A CPS report was called in, and quote, "Mom stated she will not come and pick him up, and he has been abandoned at the ER." Mom reported to our case manager that she was at work when she got the call, and that she said she would not pick him up until he had been assessed. Potato, right? So Mark refuses to go to therapy. He refuses any medication. When a DFACS social worker visited him and his family in the home, he got into such a serious physical altercation that the worker felt like they had to intervene between he and his 10-year-old brother. The worker got kicked, hit, and spit on. Previously, Mark has been diagnosed with disruptive mood dysregulation disorder and oppositional defiant disorder. More recently, conduct disorder, which ironically is going to rule him out of a lot of mental health treatment. Mark steals. He has busted out all of the windows in his family's home with a brick. He did that after he tried to cut the cord to the air conditioner unit, got shocked because he wanted to punish his siblings and make them hot during the summer because of a disagreement over a video game. He curses, he leaves the home for hours at a time. Anytime his mom or older siblings try to discipline him, he flies into wild rages, so they've mainly stopped trying. He cut his wrists with scissors. He kicked out 2 windows in his mom's car. He tried to stab his younger brother, and he told his mom he wants to kill her. Mark was kidnapped by his non-custodial parent when he was 3 years old. Years later, he was recovered after suffering horrendous sexual and physical abuse in another state and returned to his mother, who now truly does not know what to do. We put a behavior aide in the home 4 days a week, a firefighter with a squirt bottle. Since entering foster care a week ago from a CSU, he's eloped several times from the social workers trying to supervise him. One time he came back with a switchblade and threatened a behavior aide with it. He was taken to the emergency room again and sent to a CSU because foster care does not fix mental health. Another example from a child just last week. Chelsea is 14. She was in foster care for 2 years in another state before she was adopted at age 3. When she was born, she was premature. She weighed less than 3 pounds, and developmental delays were noted very early. As a young child, she was diagnosed with level 2 autism, later a mood disorder, intellectual disability, and reactive attachment disorder. Notes say she is frequently irritable, impulsive, and difficult to calm. Her adoptive family relocated to Georgia and had Child Protective Services intakes in 2019. 2020, 2021, and then in 2023, we had an open case for several months in Family Preservation Services, while a DFACS case manager helped the family navigate their insurance company and the mental health system to get Chelsea into a PRTF. We closed our case when she was admitted. The fire was at bay, but just weeks later, Chelsea was kicked out of the PRTF due to her physical aggression. In 2024, a family preservation case was ordered to be opened by the local court. The family needed assistance with the child's mental health needs and violent behaviors. They needed a firefighter. And when your only firefighter is DFACS, they get ordered to fight that fire. The family previously has refused to have an ABA therapist in the home because their schedules wouldn't permit it. The dad travels for work. He did not want a provider in the home with his daughter and wife when he was not there. Chelsea's behavior continued to escalate. She cursed, spit, broke into her mom's locked bedroom at night while we had a behavior aide in the home. She was demanding access to her tablet. She laid on the floor, screamed, and threatened to kill her mom multiple times. Hit, kicked, and threw things at her mom and siblings and at law enforcement when they were called. She once urinated on the floor at school and pushed other kids into it. She was 1013'd 11 times this year. She spent 26 days abandoned at a CSU before a judge ordered DBHDD to develop a plan. She was admitted to a PRTF where she received treatment for 8 months last year. Her parents only visited her 1 time. They seldom even had phone calls. They declined to participate in family therapy. They said from day one she could not come home. In June of 2025, we received another CPS report that Chelsea was ready for discharge, and her parents were continuing to refuse to allow her to come home. They hired an attorney. They declined all in-home services. They vehemently disagreed with the statements that they had abandoned their child, and they were very clear she could not come home and she was not safe to be with their family. The assigned investigator even noted that that the family went to dinner for their other child's 17th birthday and had a great time. They were excited. There was cake and presents, and Chelsea was not there to ruin it. On a bad day at the PRTF, Chelsea attempts self-harm. She bangs her head, and she can be very, very aggressive. She is still at the PRTF today. Now she's funded by state dollars as we, DFACS, tries to search for an option to meet her needs. Kids like Chelsea, when they enter foster care, they stay a long time with high costs, and then they become adults and they require adult care because now they're totally disconnected from their family. Foster care solves one problem and creates a million more. At DFACS, we have thousands of families every day that we are walking through the fire of addiction, poverty, parental incarceration, abuse, neglect. We are diverting critical human capital and financial resources away from those families to meet the mental and behavioral health needs of kids, because often, after months or even years of trying to navigate this complex system on their own, families give up. They throw their hands up and they say they cannot do it anymore. In fact, sometimes mental health professionals tell them to say that. Therapists, ER doctors, attorneys, school personnel tell these families that the only way to get mental health treatment in Georgia is to refuse to pick your child up. Tell them to put your child in foster care. If I, and it's my whole job, cannot navigate this state's mental health system, then there is a problem. If I can't do it, then how can we expect a family in a crisis to navigate it? I'm on the Match clinical team, and I do not have the answer. These families need a social worker. They need case management. They need someone to help them navigate a very complex mental health system and their insurance company. In Georgia, there is no other state agency that offers the intensive case management that DFACS does, which is why we end up helping families navigate the mental health system. It would be like if you asked the Department of Education to investigate child abuse because nobody else was doing it. These families need case management from a mental health team. Maybe that's through community service boards. Maybe it's through other agency. Maybe it is through Match. This is crucial to ensure that no child goes without the mental health care that they need, and no child has to enter foster care to access that treatment. I'm very grateful for being given this opportunity today. I'm grateful for your time. I'm grateful to be a public servant, and I'm really happy to answer any questions y'all have.
Thank you for both of y'all. You very succinctly gave us some great information that we need, and especially about two individuals in particular with very strong but more common than any of us like to probably recognize at times occurrences, how challenging it is. So, Representative Cameron has a question.
Yep. And Ms. Brown, thank you for your testimony today. Do you have any idea how many of these children end up as adults, end up in our criminal justice system? Because I run across this in jails. I visit jails quite a bit, and we don't have mental health beds for adults either. And last year I had a Down syndrome person who was well into adulthood, hit his mother, and there was no place. And I had to go to the jail. And finally we found a home in Chattooga County to place the person. But do you see a lot of people I don't like the term graduate, but graduate to adulthood and then end up in the criminal justice system because they can't be handled?
I don't have the numbers for that, but absolutely we see that. We see that even with our foster kids 18 to 21, where they end up in the criminal justice system, and we work very closely with DBHDD to try to find resources. And again, that's with two state agencies with lots of expertise, and we still struggle.
Thank you.
Are there any other questions or comments? Yes, Chairman Cooper.
How many of these children do you think you have in total?
In foster care,
that have come to you that you've tried to place and
Our state has started a complex care tracking system. We've just started that. Right now, I think we have about 500 plus kids on that list, but it's really hard to identify. When it comes to the CPS side, again, we're talking about hourly, we are getting calls about these families and these kids that need our resources.
okay. And do you have a second one? Is it okay? Do you have a suggestion? Since you've experienced this, what we should do, where we should put these children? Because ultimately, if people are abandoned, the state is going to pick up
Yes.
the
And
care of them.
And what I hope we don't have to put them anywhere. I hope that we can improve the case management component. Years ago, when our local interagency planning teams were much stronger and much more kind of closely organized and monitored, those teams provided some case management. But that's what I see people look to us for, is they want someone to help walk with that family. And we're just not the appropriate agency for that. So I hope we can strengthen our community service boards, some other agency, the match committee. I just think some case management and some people that will walk through this with families, and that can be collaboratively too, would be really helpful in the hopes that then they can access all the services they need to keep these kids at home. We do have lots of examples where kids come into foster care. We help them get into treatment. We can then close our case and we never hear from the family again because they're connected to the right people. It's when young people then leave either a PRTF or a CSU and re-enter crisis that they need the case management and support.
You mentioned that years ago you had those teams. What happened to them?
I think a lot of things happened. They just aren't as strong as they used to be. I think the pandemic took a lot of them out.
Okay.
The shifting to, less in-person contact. Some areas have strong ones, some don't. I'm guessing that the match committee, right, is kind of the state version of that. But they also can't handle the volume that we are getting from just desperate people, and the issues are urgent. So they need help today, not 3 days or 5 days or 10 days. And because DFACS responds urgently, we often end up supporting those families.
I take it these were people from different agencies. What were they, social workers from those agencies? Which agencies were involved?
Usually there were representatives from all of the state agencies, from the community service boards, local nonprofit and community resources, school systems that would come together for kind of complex care kids, meet and talk about them with the families present.
Was this sort of like we did this one by law, we tried to do another one for elderly, which we haven't gotten through yet, where by law on child abuse, the courts and the people you talked about from the school and everybody have to come together on a regular basis and meet. Is that what you're talking about? The same kind
A
of
similar group, but separate. But yes, a very similar group
Okay.
to the MDT group.
All right. Thank you
Yeah.
very much. Thank you, Chairman.
President Crawford.
Thank you, Madam Chairwoman, and thank you for your testimony. You provided a few examples of children that needed special care. Can you give me a little information about the specialty placement process and what type of resources are needed so we can make sure that these children have the special care that they need?
Yeah, so part of the issue is that there's not a ton of it. Georgia has 6 psychiatric residential treatment facilities. There are kids from all over the state and other states in those facilities. Approval for those facilities goes through your insurance company. Each insurance company has different rules about it and how it's done. And then there has to be a bed at one of those facilities. Most of those facilities, so again, you're talking about a psychiatric residential treatment facility, have wait lists that are weeks or months long. The other alternative is, right, a CSU, which is the short term, kind of 5 to 7 days emergency stabilization. Ideally, right, a youth could go from a CSU to a PRTF. That doesn't happen. It just can't because of bed space. And those are really our only options.
Thank you.
So Cameron,
Thank you, Madam Chairman. And don't hit me because I come out of a commercial insurance background, but do you have problems with either the commercial insurers
Yes.
exhausting benefit? Yes, yeah, that's a good question. Either exhausting benefits or denying benefits based on medical necessity, those kind of things, and you get hung up in all the gibberish.
Yes, I have not had the issue yet with exhausting benefits. I'm sure that's coming for me. Definitely with denials, but really often it's that they also can't find the bed. I work super closely with the Mayor Group on kids in foster care. And a lot of times it's also that they can't find the beds. You know, if you're looking for beds for 150 kids and there are 5 beds, what kids do you think they're going to take out of that 150?
So they triage them basically. The kind of.
They prioritize them probably based on goodness of fit.
Okay.
And based, I would say, on discharge planning. So the kids that have the strongest discharge plan will probably get the beds. The kids probably with the lower level needs will get the beds first. And I know that sounds counterintuitive, but if you're running a treatment facility, the kids with the lower level needs are the ones you're most likely to be successful with.
Thank you, Madam Chair.
Chairman Cooper.
Are you finding that we are still allowing out-of-state children to take up our beds because those states pay that hospital more money than we do? Are you running into that? I know that was a problem.
I suspect it's still a problem, but I do not have any data on that.
Okay. Sure. Okay. Because that was a problem, because the states would pay a whole lot more money than what we would pay for a child to be in. Thank you.
Any other comments or questions? Thank y'all. Good questions. Good. I have one. Just hang on just a minute. So, yeah. So, there's no doubt this is going to take a lot of creative work, I think, and cooperation. No doubt. We've got to work on both of those issues. But I'm just wondering, with the implementation of the Family First Prevention Act back in 2018, are there ways that Georgia can do that? Can creatively leverage Title IV funding to address and support the families to try to prevent this situation?
I do think there are some ways that we can do that on the preventative end. I think discussing that and looking more closely at it is something we can consider.
Any ideas at all?
I can think about it and
Please.
talk to some of my peers and colleagues.
Yeah. And if you'd like to send those to us, we can do that way, or we will have 2 more meetings. So if you come up with some great ideas, and we're going to work pretty quickly here over the next few weeks, but if you want to bring them back to us, I think that's what this is going to need without a doubt. So thank you for agreeing to do that. Appreciate both of you.
Thank you.
Thank you. And thank you for the work you do every day.
Seeing as a long-term hospital.
So next, we're going to hear from the Department of Behavioral Health and Developmental Disabilities, Dr. Christy Doyle, the Senior Director of Office of Children and Young Adults and Families. When you get settled, we'll be ready for you. And it looks like you may have a PowerPoint for us as well as a handout.
Yes, Madam Chair, the committee should have a copy of the PowerPoint? Okay, wonderful.
Whenever y'all are ready.
Good morning. I'd like to open by thanking Chairwoman Dempsey and the rest of the committee for this opportunity to speak with you today. And I'd like to introduce my colleague, Heather Stanley, who is the statewide program director for Match. We'd like to provide you with some information today on the multi-agency treatment for children or Match program. So, very quick historical overview. There it goes. Very quick historical overview. Match was established in 2022 in HB 1013 and was stood up within DBHDD when we were charged to provide coordinated support for the high needs kids in our system, the young people who had needs that were causing them to fall through the cracks and need more than the system was apparently poised to give. So specifically, we define that as complex behavioral needs whose require of care exceeded the level of care available within the state and local resources. So our mandate for Match is to facilitate a collaborative approach to removing barriers and promoting cooperation, not just among state agencies, but funders, care providers, families, anyone who has a role in assuring the care and the needs of the child are met. Our target population are children and young people with high mental health needs, serious emotional disturbances, or other complex behavioral presentations and challenges that significantly limit their ability to function and the system's ability to provide the coordinated care necessary for them. They are most often enrolled in fee-for-service Medicaid, CMO Medicaid, or are uninsured. And we will have some hard numbers on that for you. Ms. Stanley will be sharing those later. Local interagency planning teams, LIPTs, which you were just discussing a moment ago, and other referral sources are charged with identifying these cases and bringing them to Match so that their needs can be addressed. The vision of Match is to serve Georgia's children, youth, and families with complex behavioral needs, ensuring they receive the services they need at the right time, in the right place, and with the right supports to be healthy and successful. Our core operating principles include that Match is a family-centered program with family and youth-guided care planning and service provision to ensure that the families are centered and key in addressing the needs of their children. We attempt to identify the least restrictive, most community-based alternatives for care for these children and families, and to provide responsive services that reflect the diversity of Georgia's population. We are not one large group, and our children and families reflect the dynamic growing community that is Georgia. We try to implement trauma-informed and trauma-responsive services for the children and family who are referred to our care to achieve the desired outcomes and practice data-driven and data-informed approaches to assure that we are meeting the needs that families actually have. So the key outcomes, I'm always afraid this isn't going to advance. The key outcomes for Match and the children and families we serve are expanded in-state options. Representative Cooper, you were asking a moment ago about children going out of state children coming to Georgia. One of Match's chief goals is to serve Georgia's children here at home in Georgia. To strengthen family engagement and make sure that families are prioritized in the care of their own children, rather than being excluded and isolated from the care of their children. We also attempt to promote fewer emergency escalations, so fewer children in emergency departments at hospitals, fewer children in crisis stabilization units, etc. and improved access to care for children with special needs, particularly co-occurring needs. We've seen a rapid increase in children who are dually diagnosed with mental health disorders and intellectual and developmental disabilities and autism spectrum disorder, particularly autism spectrum disorder and mental health diagnoses. And to this end, Match does collect data to identify gaps, potential necessary services, and potential novel ways to meet the needs of the children we're serving. The core components of Match are the Match State Committee. This is the administrative body that manages and oversees Match and includes voices from all of the key child serving agencies, as well as many critical partners throughout the state, such as the Marcus Autism Center, Voices for Georgia's Children, NAMI Georgia, the Georgia Parent Support Network. I won't read the full list to you, but we've made an effort to engage all of the stakeholders with a voice and a role, and are always looking for new partners to invite to the table to enhance the services and connections that Match is able to make. The roles and responsibilities of the Match State Committee are to ensure compliance with the provisions of HB 1013, to review case level and system level data. So we are tracking the data generated by Match, and the Match State team reviews this data to assure that it's being leveraged to meet the needs of children and make the system an iterative system and responsive system. And in that vein, to identify the gaps in services that are being informed by the data. And then to recommend policy, funding, operational, recommend strategies to permanently address the gaps that are found in the system. The outputs from the state committee are written recommendations to the Behavioral Health Coordinating Council on regulatory, administrative, or funding approaches that might be leveraged, sharing identified gaps with the BHCC, as well as sharing pilot programs and concepts that the Match State Committee believes may be useful to address the gaps that have been identified, and periodic briefings to make sure that agency leadership is informed of these. The next level is the Match Clinical Team. This is a team that is chaired by Ms. Stanley and includes, again, representatives of all the key child serving agencies, as well as any individual who is involved in the care of the child. So if there is an independent funder, such as CMO Medicaid, the funder is invited to the table, care providers, etc., are all at the table. And again, Match is always looking for those individuals who are formative in the child's care to bring to the Match State Committee, or clinical team staffing. Clinical team staffings are scheduled routinely every other week, but staffings are convened emergently as needed as well. So we have sometimes had as many as 3 to 4 staffings per week as the need has arisen. But again, routine staffings for children whose cases are being updated or reviewed, etc., those happen regularly every other week. The casework of the Match Clinical Team is to review the referral, assemble all the necessary stakeholders and clinical documentation, and to develop recommendations not just for a specific treatment intervention, but for a full range of services, supports, and other interventions that a family and a child might need to be successful and have their needs met. We also use the clinical team, again, to document the barriers and the gaps that are being identified for each individual child as they are being staffed to then roll into the aggregate data. The basic pathway for Match is the referral is made, and referrals, we have tried to create a no wrong door approach for referrals. Obviously, the LIPTs can and frequently do make referrals. Those referrals can come from the Department of Juvenile Justice, the Division of Family and Children's Services, a hospital, an inpatient treatment provider, a school system, Again, no wrong door. Anyone who identifies a child's need may bring that child to match for staffing. Again, trying to put families first, match engages with the parent or caregiver first in order to secure the necessary consents, releases, and parental engagement in the process so that when the staffing is convened, the staffing can be smooth and information can flow freely and the parent understand clearly what the process will be and what's possible through the committee. The pre-staffing preparation is to gather the documentation that we've just discussed to assure that the appropriate payer or payors are identified because some children do have multiple payers. And in that case, the prioritization of payers must be identified and navigated, etc. And any other medically necessary determinations that have to be made from those payers, we attempt to engage or identify and clarify all of that prior to the staffing. And of course, make sure that any legal or custodial concerns are addressed prior to bringing partners to the table. This continues to the match staffing conference where all of the partners are gathered at the table to review the necessary information, address any immediate concerns such as immediate in the moment safety, stability, other critical needs, but then also to move on to medium and longer term solutions and interventions for the child and for the family. And also, again, having all of the stakeholders at the table resolve any payer questions and attempt to navigate any potential barriers or pitfalls that have been identified, such that when parties leave the table, everyone understands and those questions have already been addressed so the plan may move forward. Documentation is produced for all of the recommendations and provided to all of the parties. Recommendations for step-down care, wraparound community services, family supports, etc., again, are provided to everyone, so communication is clear and there's no confusion. And responsible parties are identified during the meeting and in the follow-up documentation, so there's no lack of clarity as to who will be doing what on behalf of the family and the child. As I mentioned briefly, Match does follow up with children and families. It's not one and done. Match coordinates further with the CMOs, the community service boards and other treatment providers, families, etc., to assure that service connections are appropriately made and executed and that services are being provided as planned for the child. As well, Match does post-staffing check-ins with the family, again, to inform and assure that services are in place and are moving as was planned and directed. And cases remain open for consultation. If the conditions change, the child will be staffed again. So the staffing pattern is responsive to a child's changing needs. We do have a partnership with the Center of Excellence at Georgia State University to track the data and are in the process of developing our first annual match report as we speak, actually, and we will share some numbers with you from that report that are hot off the presses, if you will. We also aggregate those findings for the use of the Match State Committee. And with that, I will turn it over to Ms. Stanley.
A question. Do you want to ask it now or do you want? Okay. Okay.
We're going into a different thing.
Yeah. Chairman Cook, please.
And I haven't been involved in this and except I'm referee over the years of hearing bills. Okay, I don't really understand when Match gets in and how the process works. When the social workers at DFACS get a call, or do they immediately call somebody to report that to Match?
They can. They are not required to. Match does not. We don't have a mechanism to be aware of a child in need unless somebody communicates to us. Ms. Stanley can probably talk about how that looks most frequently.
Right. The referrals come from anyone that touches that child that sees a need can make a referral to match. Because a youth is reported to DFACS doesn't automatically imply that they would be referred to match. They can be, but they don't have to be.
Well, it seems like to me, if you're trying to involve all this in the family, that would be one of the first calls they would make. I mean, are you doing the same thing? If you get the call, you'll try to find a placement for that child?
We know more about treatment than placement, but what we do look for are opportunities to partner. So if we know that the youth needs additional supports, we're not going to do that on our own. We're going to reach out to the other state agencies, to the community, and bring those individuals to the table.
If I may, Representative Cooper, as well, something my colleague at DFACS had said earlier, the family is always the ideal caregiver for their child, and that is one of the goals of Match whenever possible, to secure comprehensive community-based services for the child and the family that would help facilitate that child remaining with their family whenever possible.
I guess I see that only 80 people were referred to the clinical. I guess I just don't see where it's the coordination about the teams. And I think she said it used to be more coordination, and it seems like that if you do that much work, that at some point this should be required, that we look at if they're having that much trouble handling these children and families are abandonment. I just guess I'm losing it. Or either it's duplication of services.
So a couple of clarifying points, if I may. Not every child that receives match services necessarily requires a full staffing. Miss Stanley and her colleague, Danielle Fish, who comprise the DBHDD match team, will often provide additional services for a child as they're compiling information that then mean the child never requires the full staffing. They're able to meet the need. I believe we have, yes, ma'am, 198 kids since Match has, in the 18 months since Match has started serving kids, have been reviewed by Miss Stanley and Miss Fish, and coordination provided and service connections made that meant they never had to actually rise to that level. So there are multiple levels of engagement with the match teams.
When we get the first report, will that tell us where the referrals came from? Like if they came from DFACS or where they came from? Not trying to be critical, but in a perfect world, since we've set up this very complex team to look at this, do you think it would be better if every child was reported and at least reviewed on some level? I mean, they might not need the full reviews, but
No, I understand what you're asking. I believe, given the complexity of the cases and the family situations,
right.
that it would be premature for me to say, well, certainly, let's just do that right now. What I will say is, I believe this is an opportunity to look to enhance the process and partner with all of the stakeholders on the match state team to figure out how we can systematically fill these gaps and enhance these processes, because we are always looking for ways to be more inclusive and to enhance the match process to make sure it's serving the children who need its care.
Well, I mean, I certainly appreciate what you do and I appreciate what DFACS does, but since we seem to be having a major problem and families are just saying we're not going to take kids back, and it seems like, I know that on child abuse, the ones that are out in the community where they have the judge and the social workers and the school and everybody involved has made and they do review all of the cases on, child abuse. And then it's really been very helpful. So that's why I was asking. Thank you very much. I'm sorry to interrupt.
If you would, we've got one more question too. Representative Cameron.
Thank you, Madam Chairman. Thank you for your testimony today. But with all the different stakeholders involved in this, in what you're trying to do, what is your biggest challenge to date? You can just say one thing that's.
We do have some challenges identified at the end. My hesitation comes
Okay.
from picking
All right.
the one
Okay.
challenge.
Madam Chairman, I'll withdraw just.
Great. Go ahead, please.
Thank you for this opportunity. So as you can see in front of you, to date, we have staffed 198 youth outside of the formal match process, 80 youth within the match clinical team. And then myself and my colleague Danielle Fish have actually reviewed referrals for our match pilot. So those youth, all of those referrals for those programs come through our system, come through our email. We review and then approve or say no. They need a different level, or they don't meet this criteria, and then we offer alternative solutions. We don't just say no. We look for how else we can support those individuals. Quick snapshot of your. Oh, sorry, I forgot the. Quick snapshot of your match participants. So we see that 66% are 13 to 18, 91% have a mental health diagnosis, 59% are co-occurring, and that is typically the autism spectrum disorder. And then we have 63% that are defects involved youth on some level. So that doesn't all mean that they're in custody, but it could mean that they've been referred, or they have an open case, or that they are actually in defects custody. And then 53% have come through a crisis stabilization unit, which means that they are either that referral came from the crisis stabilization unit, or once they were released from the unit, someone in the community made that referral. And then we have 24% that have been actually in a psychiatric residential treatment facility. Early in our match clinical team process, we realized that we had some gaps that we could help fill with our urgent care funds, which would create pilots across the state of Georgia, looking for opportunities to make sure that the services that were needed that weren't available could be created, and then us track the progress of those programs and their impact. The first one that we were able to create was the Devereaux short-term transition program. It's for 18 to 21-year-old males with co-occurring IDD and mental health. And it is a 7-bed unit. What I'll say is that it is a really amazing program. Those youth and those staff have done some amazing work in motivating individuals for change, helping them identify their strengths, both internally and externally, and preparing them to be integrated into the community and live as independently as possible. They have kind of reshaped the attitude and the behaviors around the whole campus, not just their small cottage. It was originally created to be a 6-month program, and what we have found is that it really takes a little bit longer than that, more like 12 months instead of 6 months. But they have had several successful discharges, and there's currently a waiting list. So we have been very pleased about the work that they've been able to accomplish. We have several in-community intensive programs. One specifically that we'll talk about today is the Youth Villages Intercept program. Youth Villages has used Intercept in several other funding streams. Match was brought in specifically to expand that scope and make it more available for communities that were in the rural areas and that didn't have access to intensive in-community supports. They have been able to work intensively up to date with 51 youth, and they probably were the last contract to go into place, so they've only been operational for about 6 months. And their renewal is coming soon, and they've asked to expand to add more therapists and to see other counties as well. Our other piece that we want to talk about is the ED pilot that we have with one of our community partners. Viewpoint Health and Children's Healthcare of Atlanta. And what I'll say for this pilot is that they saw it was over 200 youth in a very short amount of time. And they were able to reduce the number of ED visits and ED readmissions to the point where the CHOA decided that they could handle it internally and no longer needed that external support. Because of the work that the community partners did in that particular pilot, we were able to repurpose those Viewpoint Health staff in other communities to do additional coordination for families that were in crisis.
Before we move on to the next step, I would like to say that the Match State Committee continually evaluates newly identified gaps and new and innovative ways to address those gaps. So as Ms. Stanley said, the CHOA Viewpoint Health Collaborative was successful enough to be sunset, and we're repurposing those funds. We are currently evaluating proposals for providing structured and targeted case management for dually diagnosed behavioral health and IDD youth in the community, and other case management partnerships. So that is an ongoing process. It's not, oh, we have these pilots and we're done now. We're constantly looking for new ways to address these challenges. Looking for
Matt, we have a question. If may.
Sorry.
Okay.
Before
Chairman Cooper.
I'm trying to do it where it looks like you're transitioning to something else. For these programs that were funded through you, it's a pilot project, do the child have to be referred by Match?
No.
Okay, so DFACS could also refer a child to one of these programs.
The only one that flows directly from the Match Committee is the short-term step-down program, the Devereaux program. The other community-based programs can receive referrals from anywhere, but we do have to approve if that youth is enrolled or not, and use the match funding.
And do these programs want the child to have insurance or to pay for the services in these different programs?
The match funding will pay for the service while they're enrolled in the pilot. The criteria for a match referral would be that they have CMO or publicly funded insurance. If they are underinsured, which means they have private insurance, but it doesn't cover that benefit, or if they have both commercial and publicly funded.
I guess that my only question would be, are many of these children covered by Peach Care? Our state, that's the right name, Peach Care? No. Right, are they funded by Peach Care?
No, I would say the majority of those individuals have a care management organization, so they're covered by one of the currently four CMOs.
And are they paying for it?
No, we are paying for it currently.
I mean, I guess what I'm asking, if they have coverage, do they pay for what they should pay for, is what I'm asking.
In the pilot, we have not been able to establish a way to bill those separate entities. In some cases, it's to establish that they're not Medicaid billable currently. They're not in a code that would cover that service.
And that is one of the gaps that we hope to address, Representative Cooper, is to say this is a potentially reimbursable service. We have identified the need. We can present the data. What is the state's next step? So looking forward, some of the gaps and challenges that we've identified and some next steps that Match sees as a potential way forward. I think we've already discussed when children are ready to leave a residential placement. Sometimes going directly home isn't the best choice for that child, but the state is very lacking in that intermediate step-down placement that would allow the child to successfully transition in a stepwise progression. So we are looking through match information and potentially match pilots at opportunities to expand, explore, and pilot step-down options to determine what is most effective. We're also looking for partnerships with providers to see what providers identify as necessary for them to stand up these services and offer these services, and opportunities to align the funding to meet those needs when that service is identified. We talked quite a bit about this, but children with co-occurring mental health and IDD and autism spectrum needs. This is one of the fastest growing segment of children that we are serving through Match. We're addressing this through a number of ways, including some as basic as training and technical assistance. Some providers are more than happy to try to support these children, but just don't have the skills. So we are trying to facilitate that sort of skill building and information provision that providers are saying is necessary. As Ms. Stanley discussed with the Devereaux pilot, we are also trying to create targeted and specialty services and units for these kids, and exploring bundled service options that are specifically targeted for these kids that allow a full spectrum of services to be provided that is known to be the evidence-based cohort of services that's necessary to support these children. Transition-aged youth. It seems to me that in my almost 30 years with the state, we have been talking about transition-age children in some capacity for most or all of those years. That continues to be the case. Young people who are aging out of child and adolescent services and into the adult service system are inadequately served by both. And we are endeavoring to break down those barriers and identify appropriate service transition points and services to allow these young people to successfully transition to the adult system. Warm handoffs, providers that are prepared to provide the full continuum rather than having to transition a young person to another provider, continuity planning on the front end before the situation has become urgent, and other steps. Specialty residential treatment placements in Georgia can sometimes be challenging, and options in state can be limited. Again, we are talking to providers and making every effort to recruit providers with evidence-based models to identify licensing and rate structures that may prove challenging to standing up and operating these programs, and piloting small programs to develop the data to support that larger efforts are worth the investment. Family engagement. We have talked quite a bit about Match's efforts to be family-centered. And we acknowledge that family challenges, particularly when their children are placed in areas that are remote from the parent, can be very challenging. Frankly, parents work, they have jobs, they have other children. There are barriers to their participation in their child's care and treatment. So we are trying to address the logistical challenges that families do face by providing supports with transportation, helping to reduce financial barriers when possible, helping to enhance virtual options, both for parental participation and for treatment for children and families. We have partnered with other agencies and entities to help establish interventions specifically that would allow families to receive services in ways that perhaps they have not before, such as virtual family therapy and things of that nature that don't require a parent to take off work, travel somewhere, miss a half day of work or another child's childcare arrangements, and to be more family focused in therapeutic offerings. Administrative and billing constraints continue to be a problem. Sometimes less flexible definitions of service prior authorization or minimum amount of service units that are authorized have proved to be a barrier. So we do work again comprehensively to try and identify where those service utilizations are proving to be barriers and to make suggestions on how those may be addressed, particularly on criteria for step down and intensive intensive community services, so that the system is not pushing a child into deeper in services in order to access something. We are also leveraging match funding to pilot flex funding for these pilot services and the short-term flexible services to address a child's need in real time. Workforce shortages, as we all know, continue to be a challenge, not just for children and adolescents, but for the behavioral health workforce and healthcare workforce in Georgia in general. We are exploring opportunities to engage with possible loan repayment options, tuition support programs, telehealth options, and ways to leverage virtual services in ways they have not before, and targeted rate enhancements for hard to recruit, hard to serve areas, of course, have also been under discussion. Data limitations, I believe, is a conversation that comes up in many different healthcare areas. Data collection can be fragmented. The systems don't necessarily speak to each other, and all relevant data are not necessarily collected or are not necessarily collected in ways that can be easily cross-referenced with one another. Exploration of standardized referral and tracking processes across systems can definitely help fill that barrier. Developing shared data dashboards and general investments in data infrastructure that support real-time decision-making and can talk to each other to be useful across the system. So some potential suggestions that we might have for the committee to recognize that Match is a potential partner and support mechanism for addressing the needs of these children. And of course, that Match is making every effort to be dynamic, inclusive, and responsive. So if there are more partners and more challenges, Representative Cooper, to your question, we definitely want to tackle them in a thoughtful way that allows the solutions to be developed and sustainable by the system. Encouraging collaboration and participation by partners. Potential resource support is to explore targeted investments in the step-down programs that we were discussing that are lacking in Georgia at this time, and supports for specialized residential options in Georgia. Support for flexible bridge funding for those transitional periods that we were discussing, that allows immediate barriers to be addressed while systematic enhancements and long-term solutions are identified and put in place, and evaluating the use of those flexible bridge funds to duplicate my bullet and my point. My apologies for that. And data and accountability. Again, wherever the opportunity arises to emphasize the benefits of shared data infrastructure, data sharing, transparent reporting, and leveraging of data among agencies and entities on time to placement, barriers, outcomes. As we've discussed, Match doesn't necessarily see all of these children, but are more than happy to integrate our data with and to integrate the data of similarly situated children who are being served in other ways to develop more robust recommendations. And as always, we are happy to provide periodic updates to this committee.
Thank you. I see a question. I see a couple of questions coming up. So Representative Cameron.
Thank you, Madam Chairman. Is there a geographic area in the state that's harder to provide services than others?
I would say any of the rural areas of Georgia are more difficult. Not that they're aren't any services. There's just not as robust array of services.
Okay, thank you.
Zoom call.
Thank you, Madam Chairwoman, and thank you for your presentation. One question that I have, as we were going through the PowerPoint, you convened with stakeholders to figure out what's the least restrictive clinical appropriate options. So I have a few questions. One, can you provide an example so I can understand exactly what that means? Two, what factors are considered to ensure that it's the least restrictive option? And then three, is there a review process to make sure that it's actually the least appropriate, the least restrictive option?
Sure. When we talk least restrictive, we want to see youth at home in their community, or at home with their family. So we are looking for intensive treatment in community options first. If their level of need or their inability to be stable at home in their community is not an option, then we would look for, is there a short term, a partial hospitalization option that would keep them close to home, but possibly not in home? And then if that is not available, do they need that highest level of psychiatric residential treatment, which would mean they would be away from community, away from home. But can we do it in the least amount of time possible to get them to a baseline of stability?
Okay, thank you.
Any others? Not right now, but I've got a little something else. When we go back to page 6 to the blocks, that first one that talks about 66% are 13 to 18, does that mean that the others are younger? What is that?
Yes, we have, the youngest youth that's been referred has been 6. We have not seen a significant number of birth to 6, but that doesn't mean that they are not in need of services. They just haven't been directly referred.
Okay. And then I wanted to ask you, so you're, the CSBs, the Crisis Stabilization Unit and Behavioral Health Crisis Centers, are y'all seeing this come forward with child abandonment? Are you hearing about it? Are you aware of it?
We are. It's not as, from the match perspective, it's not as prevalent as most of those referrals are. We do get referrals to match for youth that appear to be left in those facilities when the facility says that they've reached their baseline and they're ready to go back into community.
Mhm.
And if I may, Representative Dempsey, we also see a good number of children who the CSU says have reached maximum crisis stabilization benefit,
Mhm.
but require a longer term PRTF placement or something of that nature. And then the challenge of securing that bed is there as well. So we see it both. The child is struggling to return home and the child is struggling to return or to turn to a higher or different level of care.
So you are seeing some of that languishing in a placement that may not be the best for that child at that moment. And I know that's one of your priorities is to deliver the best services at just the right time. Okay.
Yes, ma'am.
Okay. Thank you. Thank y'all so much. I don't see any other questions, but if we do come up with some, we'll be in touch. Thank you for what you
Thank
do
you.
every single day. For people of all ages, actually. Yeah. So our next speaker is from Hillside, Atlanta, Emily Acker, the president and CEO. And yeah, and some others who are with you, you can introduce as well when y'all sit down. Yeah. No, please. Thank you. Great. So whenever y'all are ready, just make sure to introduce everybody.
Thank you so much. It's an honor to be here, and we are very grateful for the presence of this study committee. As a private nonprofit provider of psychiatric residential treatment, as well as community-based services, we hope we can share information for you that is meaningful and helpful, and that we can be available during the time this study committee continues forward. If we can be a resource, we want to do so. I am Emily Acker. I serve as CEO of Hillside. I will let Amy introduce herself.
Hi, I'm Amy Renee. I'm the Vice President of Community Operations and Clinical Services at Hillside.
Hello, I am Dr. Kimberly Young. I serve as the Vice President of Residential Operations and Clinical Services.
So the three of us together are going to try to give you a perspective of what this issue is like for a private provider. With the information that I provided you, you can see that Hillside provides an array of services. We our residential treatment, or PRTF, has been discussed very often this morning, is our largest service and the oldest service for Hillside that has been provided. We also provide day treatment, virtual intensive outpatient treatment, and intensive in-home therapy. We also agree a child is best served in their home with their family, and if not there, somewhere close to their home community where they can continue to get those supports from their family. We have 91 PRTF beds here in Atlanta. The average length of stay is about 109 days currently in PRTF. The kids we serve typically have about an average of 4 previous hospitalizations before they come to us. 62% have 2 to 3 mental health diagnoses, and we are seeing more complex medical diagnoses as well with the kids that we serve. 80% have engaged in non-suicidal self-harm behaviors, and 56% report at least one previous suicide attempt. So the kids we serve in residential treatment are definitely presenting with intensive mental health and behavioral health needs. Something that's unique about Hillside is that our population is about 50% funded by Medicaid and 50% funded by private insurance. The majority of the kids we serve are in their parents' custody. Out of the 90 kids we have on campus today, there are 18 in DFACS custody currently. So the majority of the kids are admitted by their parents in their parents' custody. Discharge planning most definitely begins not just at admission, but prior to admission. When we are reviewing the referrals that we get for residential treatment, we immediately begin thinking, what is the long-term plan for this child? What is our team going to need to do and pay attention to as we treat this child and family? One theme that I think you've heard already this morning is that a child may be considered the isolated patient, but they are never the sole patient or client. A child relies on family and adults to thrive and grow and be well. So just focusing on the child alone and how they have progressed through treatment doesn't tell the whole story. A family must be considered. With that said, I would love to turn the mic over to Dr. Young to give some information about a current case.
Hi, thank you for having us here today. Before I start, I want to say that our colleagues this morning did a wonderful job of highlighting the gaps in our system and the desire to not use DFACS as a placement and inappropriately, and we want to keep the children with their families. That is Hillside's desire at all times. However, as a private nonprofit provider of PRTF services, we also are dealing with the abandonment issues. And we want to highlight for you today a case that has worked out well, even though the child is being placed in DFACS custody. And it's been the most successful case where there was no lapse in guardianship or funding. So for the safety of the child and the functioning of Hillside as an organization, this case has gone well. So I'm sharing the story today of Summer. Of course, this is changed information. She's a 14-year-old admitted to Hillside PRTF this year for worsening depression, daily passive suicidal ideation, and severe self-harm. She also has displayed poor impulse control, dishonesty, defiance, and risky behaviors. Prior to coming to Hillside, she had 4 acute hospitalizations and 1 PRTF admission in 2024. This youth was adopted by her maternal aunt and uncle at age 6 following her biological mother's death and termination of her father's parental rights due to neglect and abuse. History and current presentation indicates severe early abuse and neglect, likely in the pre-verbal and preschool ages. This has resulted in significant attachment issues and this youth's inability and struggle expressed concern about her returning to their home. They had significant concerns about their ability to keep her safe, as well as their medically fragile 7-year-old in the house. They explored out-of-home placements, but would face financial barriers or were told that Summer needed to be stable within the community for a year before she could enroll in one of their programs. Due to her sexual abuse, and past, it has been concluded that returning Summer home at this point in her treatment would likely trigger behaviors requiring rehospitalization, and recommended placement at this time is in a step-down group home for her to allow continued practice with developing attachments with the family. Hillside partnered closely with the family, who remained engaged through weekly family sessions, calls, visits, and supervised passes. We collaborated with DFACS, the State Match Committee, and community programs to explore funding and placement. Unfortunately, as has been highlighted this morning, we are in need, or we do not currently have, the step-down placements that we need for a child like Summer. Despite our efforts, the family ultimately refused to allow Summer to return home due to continued false allegations towards the family throughout this summer. DFACS assumed custody the day after discharge when the family did not pick her up last month. This is different than other cases in which we could wait weeks for custody, and so we would have a child without an identified guardian. So this was very positive for us to be able to do this seamlessly. Hillside's early coordination with DFACS ensured no gaps. Hillside is now working with DFACS to identify an appropriate step-down facility. By transitioning out of the family home, Summer has the opportunity to build connections in an environment that feels safe for someone like herself, while still preserving and building on a meaningful and supportive relationship with her family. But she had to be taken into DFACS custody for us to find this option.
So I'm going to talk to you guys about a success story. This is a young man who is actually being funded by one of the match pilots. So at Hillside, we are providing in-home services. It's called the Intensive In-Home Therapy Program, and we are a match pilot, and we have found a lot of success. This story is very similar to one of the cases Audrey Brannon went over, but we've been able to keep him out of foster care and in the home with his mother, despite all of his challenges. So I'm going to tell you a little bit about him. Also changed names and changed some of the details. Anthony is a 14-year-old male living in a metro Atlanta county. When we first met him, he needed PRTF services. He had been hospitalized a couple of times for suicidal ideation attempts and self-injury between the ages of 12 and 14. He's also had a history of fighting his brothers physically and getting in trouble with law enforcement, sometimes in his neighborhood. Anthony's mom has tried Medicaid-funded IFE, Intensive Family Intervention, and also community-based intensive services with little success. So he was in need of a higher level of care. Anthony's mom drives a taxi at night. She has 2 other kids that she's taking care of. She can barely pay her bills. So she had a really difficult time engaging in family therapy. So it looked very similar to a case where a mama says, I can't do it anymore. Moms don't mean that. When moms say that, what they mean is, I can't do this alone. I don't know how to do this. And that's the approach that we take at Hillside, is we try to figure out what are the barriers that are leading to you not being able to engage in treatment, because the parents need the support just as much as the kiddos. So this young man had been physically abused badly by his uncle in the past, and so he had quite a trauma history. Uncle has a mental health history himself and has substance abuse issues himself. So this young man needed treatment to be able to move through some of that. So he was in our PRTF at Hillside for 8 months. During his stay, his mother finally was able to kind of get, and we had to adjust our schedule and get her to come for family therapy. And so she was able to do that despite possibly almost at one point being evicted and having, again, some of those financial challenges. So there was a risk of him being abandoned, but she did not. Anthony in our treatment program did learn what we call dialectical behavior therapy skills. It's the treatment approach that we use at Hillside, and basically it's coping skills for y'all to easily understand. He also was able to participate in DBT PTSD, which is a specific form of treatment for kids who have a trauma history. And so this really helped his symptoms improve, and his family was able to engage in treatment as well. Our agency, as I have said, provided him with intensive in-home therapy. We're still working with the family. We have been doing that program with him for 6 months, and he is home now. About a month after he got home, he had a hard time. He got into some fights. He re-entered school, got into some fights at school, and law enforcement did have to be called. We helped the mom with engaging in juvenile court. Sometimes that's a really scary process for families. And so we did a lot of problem solving with mom and walked the walk this summer with her, so that he's on probation now and actually under house arrest, but is doing well. This school year, he's been able to go to school and not have any incidents of fighting at this point. Our in-home therapist has been working with the mom on problem solving, budgeting, paying her bills, being creative with how she works with her young boys. And so we also are engaging IC3, which is one of the wraparound services in Georgia, so that when we close our case, the family still will have a good bit of support. So they no longer need the match pilot, but they'll have IC3 services, which is very important. So this youth is still very at high risk for out-of-home placement. This youth is still at high risk for needing mental health care, but he is stable. And we are able to also look at trying to engage him in Boys and Girls Club so that he has somewhere positive to go and be positively involved in his community instead of getting in the trouble that he's been in. And so we feel like we're at a good place, an impasse, so we'll be closing in about a month with him. So we wanted to illustrate this case as a success. Thank you.
I think what we want to be sure we communicate is that cases like this are not unique to PRTF providers, and it takes far more to help a family stay together and to coordinate services with not only with DFACS and DBHDD and MATCH, but it's far more extensive than a typical residential treatment stay. We're paid to do individual therapy, family therapy, group therapy, provide an education, and have a 24/7 safe milieu for these kids. When we're talking about extensive family support work and case management, that is beyond what is typical for a PRTF. And what I would say from my fellow PRTF colleagues is we're all having to do this. A few years ago, Hillside began funding a complex discharge planner. This is a non-reimbursed position, but it was absolutely necessary to have someone specified to support the family therapists and to support the child and family when we had a very at-risk situation and were fearful the child wouldn't be able to go home. We listed some recommendations, and what you're going to see with these recommendations is a lot of it is around supporting families. One of the things that happens with PRTF is, especially with Medicaid dollars, there's a rule that if they're in a PRTF, then other services cannot be layered on to support that child. And that's exactly what's needed. When a child is out of the home and in a PRTF, we've got a family, whether it's an adoptive family, a kin family, a biological family, that needs extensive supports in preparation of getting this child back in the home successfully. Again, it's a whole systems issue. We also feel like it is vital that home passes and skills practice sessions in the community are considered medically necessary for a child who is placed out of the home. Some funders will support us in doing home passes, letting the child go home overnight, practice those skills they've been learning, allow the family to practice the skills they've been learning, and then some funders do not. We really feel like that is a critical component. Parenting supports and education, pre and post adoption parenting supports. We see a lot of adoption cases that are very fragile, based on the child's trauma before they were adopted, and a family not being fully prepared to manage those behaviors post-adoption. Respite care. We've talked a lot about respite care in the years I've been doing this. Sometimes a family simply having a respite for a weekend, a month, to have the child go and be cared for, have some time to recoup and breathe and settle, it makes all the difference. We hear and understand DFAC's position about children coming into foster care or into state custody in crisis, and how it is a department that is not set up to manage that. We have to find a way, though, when a child is ultimately abandoned in our facility, we have to have a legal guardian. We have to have someone assigned so that we have a legal entity that is responsible for that child. We cannot serve in that way. We also need to be compensated for the services we're providing while a child is with us. We've only had 2 cases of abandonment in the last 2 years. I'd prefer that to be 0, but it was 2. Those cases cost us about $40,000 because there wasn't a funder to fund them while they stayed with us. What we also want to advocate for is that transition work is done carefully. When we've had a child who has been abandoned at Hillside while in our PRTF, we're We've got a child who is in a very precarious situation, feeling very hopeless. And sometimes, although the work that they've done in PRTF has been monumental, there's a regression, which makes perfect sense. We're not looking for an immediate move to a placement that they're not familiar with. We always want to transition a child very carefully and thoughtfully and make sure that there's a feeling of safety and support when they do transition from us. I'm happy to take any other questions. And again, we'd like to be a resource in the future should more questions become available.
Thank you. Representative Cameron.
Thank you, Madam Chairman. Thank you for your testimony. The question I guess that arises in my head is that many of these parents probably have guilt that they think they're not a good parent, and it has nothing to do with that. Do you see parents who need treatment? And now you mentioned respite care, but caregivers of any type, this is weird. It wearies people. Could you speak to that?
It does. So often when a child is in the admission process at Hillside, what we hear from parents is guilt, exhaustion, and the sense that they haven't been successful as a parent to their child. That's a very hopeless feeling. Because we work so hard to ensure that the child and family do reunite, we have to do a lot of work with that family and that parent around those issues. And what we can provide simply isn't enough. They do need a lot of outside support. And again, we would love to see where when a child is with us in residential and a family is expressing those difficulties and challenges, really having some intensive supports in that home, helping the parents and helping them prepare for a successful reunification.
Thank you. Thank you, Madam Chairman.
Chairman Cooper.
I have a couple of questions. I think. When you say that if they're in treatment, they won't pay for anything else. Some of the providers, like what kind of treatments are we talking about?
Yeah, I'll just add, ideally, what would be great if the parent is in need of their own treatment. Sometimes it's not treatment, they need parent education. So we try to do that at Hillside, but what we would love to do is be able to work with the child in the PRTF and go out to the family's house and provide parent education and support in the community like we have to do after the child comes home. So ideally that would happen at the same time. Because you can do things like, okay, parent, if you can't do it, who can do it in your system? And so you bring the family members, the kinship members together, and DFACS doesn't have to get involved because sometimes we've been successful with trying to find another place for the child to go live. If you can't live with your mom and dad,
Yeah.
Can you live with aunt and uncle? Maybe that's a safer place because there's 4 kids at home. So we've been able to work cases like that, but it takes a lot of resources to be able to go out to the community while the child is in PRTF. So that's an example.
And like the lady that drove a taxi and the family she could barely pay her bills. When y'all talked about helping, do you, and here again, it's going outside that, do you suggest other resources through the state and try to help them like get on, if they needed Medicaid?
Yes.
Yes.
Yeah, absolutely. I mean, it's case management, but it's really clinical case management. So our staff that does in-home supports knows the resources in a community.
Okay.
And knows how to help a family. And that case was staffed at State Match, so we are using the resources, local interagency planning teams. We're going to those different entities to be able to help stabilize a family. So absolutely, that's important to do, as well as provide the direct service and coach the parent on the skill. So at Hillside, the child is learning these coping skills, so is the parent, which is equally as important. So if they're not getting their own mental health treatment from us, at least they're getting psychoed and parent education and how to parent a child with these complexities.
Right. And I guess my last question, where are you? Are you nestled down in a little wooded area, in an area that nobody knows about? At least I've been
No,
here.
ma'am.
That
We
it?
are 3 miles from here.
I know.
So Hillside is located across from Piedmont Park. Our in-home services, our campus is here in Midtown. Our
Right.
in-home services, we have a team in Savannah. We have a team in Greater Metro Atlanta. And so we're going outside of the Greater Atlanta area and providing services. all
But you
over.
do in-house where you also have a school and everything?
Yes.
I'm trying to figure it out.
We have a residential campus in
Right.
Midtown.
Fine.
And then we have community-based services all over Georgia.
I visited and I was
Yeah.
very impressed. Thank you for all
Thank
you do.
you. Thank you for the opportunity. Mhm.
Any other questions or comments from the committee? I've got just one. So, you mentioned some of the reasons that parents are feeling they can't carry forward and bring that child home for so many. Guilt, exhaustion, feeling they're not a good parent, they've lost hope. It's dangerous at times to bring someone into a family. Are you seeing any common themes, particularly? I know those are, but are you seeing anything else that makes you say, oh, here we go?
I will mention, the one that we didn't mention is adoption. So a lot of the kids are adopted in an early age, 5, 4, 3, and the family couldn't predict that they were going to have issues as an adolescent. There's a lot of unresolved grief and loss that we find in those cases. Perhaps the family that adopted had fertility issues themselves and never grieved that, or they had a magical thinking that this child was not going to have issues, although they came from a biological family with mental health issues. So I would say that's a big one. Any other themes?
Say, in general, since the pandemic, families struggling with financial resources is extremely traumatic for them and difficult for them to find. So many are unable at times to participate in a family session except for their 12 o'clock lunch break. And we could give them all of these resources, but they're working 3 jobs to, support their family and have a roof over their head, and they can't access the resources for those reasons.
Okay. And then, I know, Dr. Young, you spoke about codes.
Mhm.
Are there some things you could do that you don't have the codes for?
Codes.
Yeah, in the
Oh.
yeah. Mhm.
It's like,
Did I have it? Did I have it backwards? Who's supposed to?
I don't remember if I said it or not, but
No.
there are intensive family intervention is pretty much the only
Reimbursement.
mental health reimbursable Medicaid service. Anthem Blue Cross Blue Shield has actually done a contract with us. They use Sandy Hook and found a code that we could bill here to do in-home services. So we've had a commercial insurance contract for a long time, but it's hard for insurance companies to find a code that works within their system. It took us 2 years to get that contract pushed through so that we could do in-home services. So we need a lot of creativity and flexibility and out-of-the-box thinking for sustainable in-home funding, which I know the match committee is taking on, and they use us as a partner. We're with them talking about this all the time, how we can do more of this. This is what families need.
Which service was that?
That's the intensive in-home service.
Yeah.
Mhm. The
Insurance.
code, Anthem Blue Cross Blue Shield has done a code. It's H2021 is the name of that's the code.
Fixed code or?
It's like, it's a, yes,
I see.
yes. It's a billing code.
Yeah.
And it allows you to do some of the flexibility that I was talking about, where you go out to the family's house and you're able to do pretty much anything and everything it takes to make it work with this
Right.
family, which is what it took with this young man.
So the provider can be reimbursed
Correct.
as needed.
Correct.
They could make new codes. They do that for things.
It's a code that exists. So.
That's
Yeah.
great. Thank you for
Thank you
the
so much.
creative and good work you're doing. I appreciate it.
Thank you.
I believe that we are about to take a lunch break right now for the speakers and the committee. We do have lunch across the hall. And I think, what time would you like for us to come back, Amber? What do you think? Let's go home by 4. We've got 3 more speakers, I believe, this afternoon. So you want to try 45 minutes or so? So about 12:45. We'll come back and get back to work and get everybody maybe out of Atlanta before the traffic gets too bad today. Okay. Thank you so much. Oh, everybody's so quiet. Welcome back. Thank y'all. We'll thank Becky Riles for our lunch. It was great. Those of us who were in there. I don't think she is here, but she was taking good care of us from afar. So that's really good. I think we've had a great morning. We're going to get back to work here. Already seated and ready to go to work. From Laurel Heights Hospital, Corey Jackson, the CEO. And if y'all will just introduce and tell us a little bit about yourself and then jump right in. I understand we have a brand new, is that right?
Yes.
Yes. So replace this one with
With a news.
this one.
That one was,
Do this one. Great. Thank you.
Thank you.
Mhm.
We're not even doing the picture.
Okay.
We're using this one.
Mhm.
yes, correct.
I can come with this.
There was a data change, a tiny number that had, yes.
Yes, ma'am. Well, Madam Chair, thank you for having us and members of the committee. Thank you. My name is Corey Jackson. I am the CEO of Laurel Heights Hospital. And I have with me today, Ms. Sonia Rice.
Hello, everyone. And again, thank you for giving us this opportunity to speak. And we are super impressed, of course, with the work of the other agencies who have gone before us today and the dedication that they share in trying to meet the mental health needs of the children in our community. At Laurel Heights Hospital, we're a little bit of a hybrid. We do treat children in an acute crisis area as well as in a psychiatric residential treatment area. So we have that inpatient continuum of care. You would think that you might find instances where we have issues on the residential side of children being abandoned. But as Mr. Jackson goes further into his presentation, we see those issues of the same latitude that was questioned earlier about do CSU see it? We definitely see it. I'm the community relations director as well. So I'm partnering with the CSUs. I'm partnering with the other PRTFs, with the outpatient providers. I'm getting questions from families, especially those that, yes, they do feel they don't have any hope. So we are on board with trying to work together collaboratively with our kids who at any given time are 50% to 75% with a co-occurring autism diagnosis. Half of our acute beds are for kids with autism. And I would say 70% of our children on residential can be level 1 through level 3 autism spectrum disorder. So in the overview of the information that Mr. Jackson is about to share, we also do have our own ideas of how we can help, but definitely want to collaborate with everyone else.
Thank you. We are aware, as we discussed before, that child abandonment is when guardians do not retrieve their kid from hospitals. When that is coupled with the lack of emotional support and involvement, it definitely adds to it. Children are admitted to mental health hospitals when they are experiencing immediate psychiatric crisis in which there is a need for short-term stabilization. Also, prolonged behavior issues which require long-term stabilization, which is what we talked about earlier with PRTF. And that is required for average of about 100 days for Laurel Heights Hospital, and short-term on an average of about 7 days at our hospital as well. Abandonment in this setting causes issues for not only the guardians, but the hospitals. For the hospitals, there are a limited amount of beds throughout the state. Not having youth picked up from these hospitals prevents other youth in need from getting care. Also, medical necessity, it determines when determines when treatment and funding is necessary. When medical necessity is not met, the hospital is forced with the ethical dilemma of housing in a medical setting. For guardians, the hospital provides a secure and structured environment that relieves them when they feel the youth is a danger to themselves or to the household. There's also a neurological and physiological impact to this. Studies show that abandoned children have significantly less brain volume in the areas tied to emotion and cognition. In addition to this, they also have impaired memory. On top of this, we also have a continued cycle of trauma. This also presents with emotional dysregulation, low self-esteem, and attachment disorders. This increases the rate of psychiatric disorders and continues the cycle of abandonment for future. For Wellness Heights Hospital since 2023, we have had a total of 69 patients with Georgia Medicaid abandoning care. This is a financial impact of upwards of $700K, most coming from our short-term care. Hospitals are faced with the ethical obligation of keeping youth in care versus unsafe households. We are also limited in decision-making when medical decisions are present without guardianship, meaning we don't have the ability to do what is needed with no one taking responsibility for the youth. Insurance companies oftentimes end funding before the psychiatric symptoms subside, leading to an increase in mental health need. Emotionally, clinicians experience regression in their patients, oftentimes leading to them taking a surrogate role. And the amount of abandoned youth that we have leaves them feeling like the system is broken and they are ineffective. We are coming up on a crisis where we will need more clinicians in the state of Georgia. And if we're feeling that they're ineffective, they'll be less likely to, number one, stay in the state of Georgia or come into the field. Some solutions that we thought about that we can come up with is, number one, is clinical interventions and innovations. Some of the instances we have with abandonment patients come from the parents. So a suggestion is to put out the ACE testing, which is a trauma testing for the parents prior to them or while they're in treatment, so we can see the level of trauma that the parents or the guardian had. Also, family engagement programs, virtual parent trainings, especially for autism patients. And we talked earlier today about services in rural areas. So having these virtual parent trainings and things of that nature will impact their ability to feel comfortable and confident for the patient returner or the youth returning back to their home. And lastly, policy reform. We spoke about medical necessity and evaluating what really is medical necessity. Oftentimes, the behaviors that are shown in the community is not shown in a hospital. At that point, the child is deemed not medically needed for that level of care, despite continued work that needs to be done. When we talk in trauma and we talk trauma-based treatment, it takes a while to be able to break down the ability for the patient to feel comfortable and confident in our ability to really hear them out and really build a relationship before the work even gets started. If we're basing that based on the behaviors that were shown in the community, that may not be shown in our setting. Also, we want to hold the systems, not just the parents, accountable for the work, okay? The families have to be able to have resources while they're in treatment to be able to feel confident and get the skill set needed to receive the child back. Lastly, we want to increase the accessibility for residential care. We have a very limited amount of beds throughout the state, and it is very difficult to have beds on our property, right? Because we're landlocked. But throughout the state, what we want to do and want to see is more accessibility for beds for patients with extreme behavior needs. So in closing, we definitely have an issue. However, there's life after abandonment. We have to all work together. Healing is going to require us to have connection and not just isolation. Thank you very much.
Yeah, we've got a couple of questions already. Representative Cameron.
Madam Chairman, thank you for your testimony. Question, when you have a denial from an insurance company, how often are you able to provide information to overturn that and get an additional day. So they give you 20 days and you say you need 45, whatever. How successful is, and if they are denying, are they using a different set of medical necessity guidelines than say you do? And you can't, it doesn't,
The medical necessity changes.
thank you.
The medical necessity seems like it changes every time we have we go to have a review. Oftentimes we are able to recently, we've been able to overturn about 70% of our denials, which is a lot better than
That's
we
good.
have been before, right? The issue that we're having is that a patient will come into either long-term or short-term stay, and we're having these reviews within 24 hours in short-term stay and within 5 to 7 days for long-term stay. Imagine the work that you haven't even begun to do within a week's time. Oftentimes, we're not able to get in touch with the family. We're not able to have any connection with the patient, and we're having a review to get the days continued. So that becomes the issue that we're having with denials.
Thank you.
Yes, sir.
Representative Crawford.
Thank you, and thank you for your presentation. You actually answered one of the questions that I had, and that was the frequency of the reevaluation. I think the next question that I have is, what factors are you looking at once you're reevaluating? How does a person get on the reevaluation list?
The factors that we are often faced with is really a danger to self or others.
Okay.
If they're no longer a danger to themselves or a danger to others in treatment, then if we don't have the ability to talk towards the family dynamic, which can help the cycle of trauma or can really display what we're actually working on in treatment, then it won't be approved, we'll get denied. And we know that there's still work to be done.
Thanks.
Got it.
Okay, I want to look back on page 5 with the chart here,
Correct.
data. So I'm understanding this right. Y'all had 69 children
Correct.
that were abandoned.
23. Yes, ma'am.
That's a large number. That's really high. And 22 of those had autism.
Correct.
And it was over $700,000.
Yes, ma'am.
So let's talk about the money first, then we'll talk about the kids. So what did y'all do to recoup that? How'd you do it?
We had to write it off. We had to write it off.
Okay.
We write it off to charity, which we're obligated to do, but
Mhm.
we didn't recoup those funds.
Okay. So then the children, that large number of children, where did they go? What did happen?
Eventually, we was able to find either another placement that was suitable for the level of care, or we worked with the state on various different outpatient providers to get them back in a home. But it did take some time. My colleagues from Hillside spoke earlier about the amount of time that it takes to really connect all of those dots to get someone placed. So we were able to get those kids placed outside of the facility, but not without. And a substantial amount of time.
So when you say substantial, like what was your longest, if
My
you can recall?
longest after discharge date was a year.
A year.
Yes,
It's a long time.
that's a long time.
So what happens to that child during a year? What's going on? I mean, I just want to know what a life,
The life of a
what's
child. The life of a child with a discharge date, let's say today, and we're saying that's going to take us a year. What happens is the child is hurt. They feel defeated. They feel as though no one cares. That is able to be sustained for a little while with the relationships that are formed from the clinicians and the youth care workers that are working with them. And I would say after about a month or two, and realizing that this is real, we start to see the regression. Regression looks like what the child presented prior to coming to treatment. The fighting may occur, the self-harm may occur, the lack of motivation to participate in treatment, the lack of motivation to follow instructions and follow the program. Then after a while, it will lead to some property destruction. I would say last year we had over $535,000 in property destruction on our campus. And so we, as a hospital, will continue to try to individualize treatment for that particular patient. However, when that behavior is shown, it says to the outside community is saying, this child, we told you this child was not ready to go home. When in all actuality, 5 months ago, 4 months ago, 30 days ago, this child was absolutely ready for the next step in motivation.
So do I understand that they're still getting services
Correct.
that you're paying for, but perhaps they're changed from when they first arrived? They're not in the crisis, maybe,
Yes.
but they have new crisis going on, new challenges to deal with that they didn't arrive with even.
Correct.
Okay, that's really good to know. So, what
And that's where the surrogacy comes in.
move that?
I'm sorry,
Yeah.
where the surrogacy comes in, where you see therapists and teachers on the residential side outside of acute
Mhm.
and administration and all of us trying to lift that child up. We see them with their head down.
Mhm.
We see them not participating in recreational therapy or any other special activities that we have. So it's, again, almost adopting them to lift them up. And is that a true therapeutic model that we want for the kids? That we don't want the other kids to see that we're giving special treatment, but that child needs special treatment.
Mhm.
So again, it's just not the environment to help foster their self-esteem, but we step in and whatever it takes, we do.
Right.
Yeah.
And depending on where they are on the spectrum, they're realizing that others are coming and going too.
Yeah.
And they're still there. That's become to some
And
degree.
while we have this up, I do want to point out that majority of the number of kids that was left or abandoned in treatment came from short-term care. Meaning short-term is for anywhere from 7 to 10 days on average.
Mhm.
We've had patients in short-term care up to 8 to 9 months before finding placement for them to go. And short-term care is different from PRTF because we don't get to school there, right? We don't have the ability to go on outings and passes and things of that nature. And so we really have to be creative to keep the kids motivated in a short-term setting, even though they may not meet criteria to go to long-term care. We still have to find a way to keep them moving forward because as behavior starts showing again, that's another barrier of them going to their next level of care.
Mhm. Hmm. Okay. So, the families that you're seeing, any difference in the number of biological families versus guardian versus foster versus, are you seeing more of anything? Just noticing it. I'm not going to hold you to like this was a sworn affidavit. Just
No,
curious.
Absolutely. I think we see a lot recently. We found a lot of the guardians that are foster or adopted and things of that nature tend to lean more on the abandonment side of things.
Mhm.
Definitely a difference with autism spectrum patients. And there you can somewhat empathize because it's so difficult to have resources in a community with that particular population. Oftentimes when they're leaving short-term care, they're waiting 30 to 60 days to get an appointment in an outpatient from an outpatient provider. So as a guardian, you've waited 7 to 8 months to get treatment. Now you finally have it. And we're saying within 7 days, they're not meeting criteria and they are due to be discharged. And the families are saying, no, this is not enough time. Even though that behavior or what we deem medical necessity may not be present outwardly or it may not be displayed. There's still family work that needs to be done. There's still behavioral goals that needs to be met. But those families tend to say, I would much rather that you guys help find somewhere rather than bring that child back and try to do this cycle all over again.
Mhm. What are your ages?
6 to 17.
Are you seeing more of it in any particular area of abandonment?
It's all over. It's all over the spectrum, to be honest. Right now, we have more of preteens in our program right now. So we're seeing more of the preteens at this current time, but that could fluctuate.
Young, really, really young. Okay, so what do you think maybe the parent or the guardian, what is the number one thing you think we could do to help them along? Is it respite care? Is it what are they? Is that like I don't need this back yet? Is that, you know?
I think our colleagues said it best. We need to simultaneously work with the families while they're in treatment. They have to have in-home. It has to be a mandate. It has to be something that the families have to adhere to know that, hey, you're not in this alone. And when we're having challenges where we can't dual treat because of insurance reasons and things of that nature, it puts a barrier up. And it says, okay, we're going to work with the child right now, and we'll get to the family later. Oftentimes, there's trauma in the family. There's things that we don't know, and so that family needs help to run side by side with the treatment that we're giving the youth. So, I think honestly, having more in-home wraparound services, intensive services with the family, individual sessions, because we offer family therapy. But if I know in my mind that I'm not going to allow my child back in the home, guess what I'm not going to do?
Yeah.
It's family therapy. So how do we have a mandate that you have to participate with this, but also we have someone in the home to get you comfortable and confident to be able to speak towards this? The families are tired. Right? The families are tired. There's not a lot of resources to help them. But if we find a way to connect all the dots and figure out what we can do in the community for the families, I think we can have a greater outcome.
That's great. That's great. Thank you. We've got a couple more questions for you. So Representative Crawford. No, sorry.
Okay. Thank you. I was just curious about scholastically. These children have a hard time catching up scholastically, and does that have an effect on their treatment?
Absolutely. The good thing
Thank you,
about
Madam Chairman.
I apologize. Thank you. The good thing about our facility is that we do have our education program that will help the patients catch up on their educational credits. And so it does provide a barrier for them scholastically when they're coming in, but we're able to work with them individually to get them back to where they need to be, oftentimes a little bit further ahead when they're with us for long-term care. The downside of this is that when you're short-term care and you're staying long-term and short-term care, you're that much further behind when you go back into the community.
Okay, thank you.
Representative Cooper.
Yeah, I just want to clarify something. Okay, so when you have a child that the parents say that they're going to abandon them according to our rules, you can't do any kind of treatment on them until what happens? You apply for temporary guardianship but first of all, can you do any more treatment on them?
We continue to attempt to have them engage in family therapy. We still call weekly. We still try to engage them. We try to engage them individually. If that's not effective, we try to get with a caseworker. Insurances normally have case managers and care coordinators that we try to collaborate with to try to get them engaged. If not, we do run to the phone to get DBHDD or DCS involved, DFACS involved, to say, hey, we have this potential abandonment. Here's something that may be coming down that we may need your help with. So, but we just try to engage the family.
But you're still treating the child.
Correct.
Okay, and so we've got a child that's going to be there for a while. When does the insurance company quit paying? Then?
It depends on typically within 30 days. It's really a 30-day window of where we have a review. If there's no outward indication of danger to self or others, then there's a potential for them to stop paying after that time.
Okay, so it really starts as soon as that would be when they're you say they're ready to go home, or they need to go home and they don't go home, so it starts immediately.
It starts immediately.
Okay, I'm trying to get the process. What happens then? Who becomes responsible? Who goes to the court so you can get paid? Or what happens?
Yeah, we want to talk about that. Continue.
Well, it's immediately trying to find community partnerships to help. And yes, we do go to the Department of Family and Children's Services to see what can be done. We also have the medical director and our treating MD of course, of what any issues are. They're not going to stop medication if it's going to be harmful to the child.
Okay.
You know, so not that new prescriptions or anything are going to be done or new therapies, but we do also have to address that abandonment with the child. So no, treatment does not stop. We go to the Department of Family and Children's Services. We do.
Okay, can somebody tell me what happens? Are the family and people from, or did they leave us, the ones from DFACS? Great, guess they went back after lunch. Okay,
But I will say they do try to bring us all together to talk about what services in the community we can do. We've had a lot of conversations bringing in DFATs and the committee that was here before, presented before the match committee, those teams and try to, coordinate what we can do in the home before it gets to a true abandonment.
but
We hear that other acute hospitals call the police and try to press charges on the families. We do not feel comfortable doing that because we don't want to return the child to a home that the policeman said, pick your child up.
okay, have you had a child that was abandoned for 5 months?
Yes, absolutely.
And what happened?
The child stayed with us until we can find a place or a guardian or someone for them to go to, or a different level of care. So if they no longer need residential level of care, if there's something out of state or something that they qualify for, we'll try to find that next level or lower level of care for them.
Okay, I just wondered when the court has to get involved. It's not
Yeah.
y'all.
Yeah, they have around 45 to 60 days for the hearing to take place. So up until that time frame, we're trying to figure out something for the child to do. Once we get an outcome of the court that says they are going into custody, then we're able to know what moves we can make from there. But until that time frame, we're still trying to find a place or what's best for the child.
Okay, I guess I was just trying to find out who's responsible for appealing to the court so that something is moving to try to get to some determination. Y'all don't know who's responsible for it?
No.
Would somebody else like to add in? If you got one over at Hillsdale, what happens?
That doesn't, we would go to the top levels of DFACS and ask for.
Or the top level of DFACS?
Ask for assistance. We've never had a kid that didn't have DFACS take custody at some point. So there has to be a parent, right? There has to be a guardian, and so sometimes you have to go level
That,
to get some assistance.
so that's what you're saying is if the parent's gone and you need it and nobody responds, then you would go to the top level of DFACS. Right.
Or if it's screened out, we wouldn't take that as the answer. We would go up the chain of command.
And like Mr. Jackson said, it still will take 45 to 60 days where we're kind of in limbo.
Okay, thank you. It's a long time.
The statement, Madam Chair, is how we feel. It's too long not having a guardian. There's no decision that we can make during that time frame for care. We can't change anything. We can't get additional medication. We can't do anything that may be needed because we have no one to put that responsibility on.
So just to clarify, I think what you're talking about is when you say we find something, someone for the child, who is finding it? Who's the active hands-on working to find it? If it's not the courts, if it's not, who is doing that work?
For us, our case managers
Okay.
are definitely involved in that process, and they will coordinate with the families or any potential guardians or the community support providers.
Sometimes the parents might get back involved if they believe that the child's not coming home and if we're able to find somewhere else for a child to be treated.
So not
Sometimes they
like ready to abandon, but just can't do
abandoned and now, but yes.
can't do now.
Yep.
But want this child to have care, appropriate care somewhere. I know in some of the conversations that I've had leading up to this, some of the providers have said, we pretty much know almost immediately if that parent or guardian is coming back. It pretty much presents pretty quickly. Would y'all agree to that?
In every family session, discharge planning is discussed. So the case manager therapist knows immediately when saying, in 30 days, 45 days, and 90 days, let's talk about the providers and what the home will look like. And they'll immediately say, oh, they're not coming home.
Yeah.
And then, of course, the team tries to work with the family to give them the tools. We don't take that as okay, they're meant. But yes, they know up front pretty quickly.
Keep trying to move the no to a yes.
Right.
Yeah. Okay, I want to remind the committee that we did receive at the very beginning this one page that outlines the laws and parental rights on abandonment. It's something we're going to really be looking at as we go through these sessions, but just kind of get familiar with that and understand how long it really takes today in Georgia for abandonment to really be declared. Yeah, even though all of y'all realize it has happened. So thank you for all that you're doing. I don't see any other questions right now. If we have some more, we'll be in touch though, and thank you.
Absolutely. Thank you for the time.
Got myself off there, sorry. Next, we are going to hear from Voices for Georgia's Children. Leslie Kelly, the Senior Policy Analyst. Fine.
All right. Good afternoon, Madam Chairwoman and committee members. Thank you so much for giving me this opportunity to come and speak with you. I think Amber actually passed out some handouts that I have. These are not required as I present. Oh, they were some additional handouts. I think she's doing that. So these aren't required for you to follow along as I present. It's just some supplemental material that may be useful to you after the presentation. So as Madam Chairwoman said, my name is Leslie Kelly. I'm a senior policy analyst at Voices for Georgia's Children. My presentation today is going to focus on how psychiatric lockout happens, examples of how other states are addressing this issue, how those state models compare to what is happening in Georgia, particularly pertaining to match, potential intervention points and services to prevent psychiatric lockout, and some recommendations for you to consider. And my apologies if some of this is repetitive. It's just the nature of going fifth. Okay. Okay, so this first slide is, it illustrates a simplified sequence of events that can lead up to psychiatric lockout. We've kind of talked a lot about what that looks like, once the child is abandoned. But this will kind of start before that process. And I do want to point out that this process is not always linear. As defects previously discussed, many children cycle in and out of crisis and care multiple times before they even reach a PRTF, and they may continue to cycle after being discharged from a facility. Also, this is not where the process actually starts. A child can begin showing signs of mental illness or disabilities at age 3 or 4. And by the time we reach the point of the process shown on this slide, there are many steps and opportunities for prevention that have been missed or were not effective. But for the purpose of this presentation, I'm going to begin at the point where a child with complex mental and/or behavioral health needs exhibits acute behavior that requires intensive community services. So these children often have multiple serious diagnoses and behaviors, including violent, aggressive, or sexual behavior, which can be very challenging for the family. These behaviors can include attempts to cause harm or actually causing harm to a family member, as the previous presenters discussed. Additionally, the family may have experienced generational and ongoing trauma, which can make it more difficult to manage the child's acute behavior. And on top of this, a lot of these families lack basic social supports like safe and secure housing, transportation, and childcare, which can make it even harder to sustain the child in the home. We know from research that for any intervention to be successful, these basic needs must first be met. So then in the next box down, we see the child going into crisis and the child cannot be treated safely in the community. The child is then admitted to a hospital or a PRTF, receives treatment, and is then discharged. And when I say discharged, this means that medical professionals at the facility have agreed and determined that the child's treatment is complete and they are ready to return to the community. So in this last box, we see the parents or guardians refuse to pick up the child, and the child is going to remain in the facility until the parents or guardians agree to pick up the child, defects takes the child, or the child ages out. Typically, abandonment time is about 5 weeks, and 6.5 months is the maximum reported stay post-discharge. Okay, so I did notice that Laurel Heights data is very different from the data that I received. I received the data from the Georgia Alliance of Therapeutic Services, and I believe Cheryl Dresser previously did email this to the committee. I'm not sure why there's such a great discrepancy, but I just wanted to let you know that was my source for the data that you see in this slide. And I'm not going to go through the slide in detail, but for the Georgia Alliance of Therapeutic Services reported that during this time period, which is July 2023 to June 2025, 18 youth were abandoned in facilities. And I think Laurel Heights said something like 60. So that's a big difference. I'm not sure if the definitions were different, but the slide is just going to show the facility type, the payor, so that could be Medicaid, private insurers, and or waivers, the diagnoses that the children had, the ages of the children, which range from 9 to 17, the reason that the parent or the guardian refused to pick up the child. And again, this is mostly due to safety issues or an inability to manage the child's behavior and needs. And then the last column shows the number of unpaid days that the child remained in the facility after discharge. And just FYI, it was reported to me that 3 children were abandoned in CSUs during this time period, but I don't have any additional information for them. Okay, so Chairwoman Dempsey actually asked me if we had looked at what other states were doing to address psychiatric lockout. And I have included Illinois and Washington as some models or some examples of model programs that are working to address psychiatric lockout. So Illinois uses a specialized family support program, and this is a 90-day voluntary program administered by a multi-agency team and designed to specifically support the needs of families at risk of psychiatric lockout. The program uses...
One second. And
Yeah.
Can you give us what your definition of psychiatric lockout is?
Yes,
'Cause
I'm
that's a
sorry.
new term.
I've been using that in place of abandonment. So psychiatric lockout is when the family does not come and pick up the child. So it's in lieu of abandonment. It's just maybe a little more technical term.
So discharge has
Yes.
happened.
Yes.
But isn't happening, and it's called psychiatric lockout.
That's correct.
Great.
So the Illinois program uses intensive case management, crisis intervention and stabilization, community-based behavioral health services, therapeutic support services, and family support services to help maintain the child in the home. This program uses blended funding with insurance as the primary payor, and that's followed by SSI, SSA, and other state benefits. Just to note, the parent is ultimately responsible for covering any costs that are not otherwise covered. Washington also uses a multi-agency rapid care team made up of state agencies as well as a parent peer liaison to communicate with and support the families. The rapid care team also contracts with providers that assist in filling service gaps while the team looks for long-term solutions. The rapid care team uses flexible state funding to support the safe discharge of children in crisis from hospitals and for long-term and appropriate placement for children in crisis who are dependent. This is just a basic description of these programs, and the one-pagers that I passed out, or Amber passed out to you, describe the programs in more detail. Okay. So we took some of the components of the Illinois and Washington state models and bumped them up against what Match is doing in Georgia. As you can see here, Match is a multi-agency team that can coordinate services and funding. Like Washington, Match has parent peer representation on the state committee and its clinical team. It does not, however, have a final decision-making entity or process with the power to direct an agency to take action if necessary. Early identification of psychiatric lockout is another essential component to prevention, and Match does have the ability to take referrals from hospitals or PRTFs if they believe that the psychiatric lockout is imminent. As Dr. Doyle told you, Match has a no wrong door referral policy, and they accept privately insured youth as underinsured, or if the youth is covered by both public and private insurance. Another component of the model is a designated funding stream to pay for gap services or services not otherwise covered by Medicaid or private insurance. Currently, Match is using social services block grant funding for urgent care, but there's not a designated stream of state funds that Match can use at its discretion. Concurrent planning also needs to be in place to address the changing needs of the child and the family, and Match does have the ability to do this. And each child and family needs individualized solutions to fit their needs and intensive case management to navigate systems and ensure that they are getting the proper support in a timely manner. Match offers individualized solutions and uses care connectors to bridge families to CMOs and other resources. And the last component is data collection and ongoing evaluation. And these are keys to improve services and identify barriers to treatment. And this is something that Match is currently doing, as you heard from Dr. Doyle. All right. Here's the big slide. So this slide is going to show you the same process that you saw in the first slide, but then it also identifies potential intervention points and services. So before a child goes into crisis, it's crucial that the child and the family receive preventative services to prevent the hospitalization and/or the residential treatment. Once the child is admitted to a facility, the family should be referred to a multi-agency team, Match, to begin connecting the family to services and begin the discharge planning right away. The family should also receive parallel services while the child is in treatment. And this is really to address the trauma that all of the family members experience when they live with a child who has acute and often violent behaviors. You heard about some of this from the providers today, and I know that Sue Smith with Georgia Parent Support Network will also speak to this when she presents. So when the child is released from the facility, a comprehensive discharge plan and intensive community-based and in-home services should be in place for the child and the family. I want to emphasize that these services are key pieces of the intervention process, and they include those respite and step-down placements, the respite care and step-down placements, which, as Match mentioned, are not widely available in Georgia. Some of the previous presenters also talked about support for parents. In addition to therapy and in-home services, parents and guardians need peer support through this entire process. And this is really due to the shame and fear and stigma that comes along with being in this situation. As has been mentioned, parents and guardians have experienced their own trauma, which can be generational, it can be personal, or it could be related to the child. And peer support is crucial to help the parents not only manage the child's behaviors, but help the parents manage their own mental health and well-being. Intensive case management, which you heard before, is another key component of prevention. And like peer support, it's really a through line to this process. It must be ongoing, and it must include the family, agencies, and the payors. So a number of the services that I just mentioned are components of Medicaid's proposed therapeutic care model benefit, as well as a special match work group between DCH, DVHD, and Voices for Georgia's Children that's currently working to make match pilot source services Medicaidable when possible. And I'm sure DCH will talk more about that when they present. So at this point, if the parents or the guardians are still unwilling to pick up the child, they need to be informed of the option of entering a voluntary placement agreement with DFACS. This voluntary placement agreement would allow them to retain legal custody of their child until they can hopefully take the child back into the home. Although it's not ideal, a voluntary placement agreement would allow the family some additional time, 90 days, and could be extended to 180 days to get the care they need and put services in place before reunification with the child. Ideally, Medicaid or private insurance is the primary payer for all health services. DFACS pays for placement and some prevention services if needed, and minimal behavioral health service gaps are going to be paid through the state and federal funds via DBHCD and DFACS. With regard to the family, parallel services could be paid through the other family members' health insurance, because in those cases, the family members would be the primary patient, but that would rely on the caregivers or siblings being insured, because as we spoke about, Medicaid will not cover for parallel services for the family while the child is in treatment. All right. So we have some recommendations, and I'll try to get through these really fast because I know I've been talking for a while. So I've broken down the recommendations by agency or organization. DBHC should provide funding to support increased provider capacity for transitional services. So these are those step-down placements, the intensive outpatient and in-home services, and the respite care to allow children to return safely to their homes. DBHCD should also continue leveraging social services block grant funding to help support match operations, programming, and fill service gaps. Match should leverage the clinical team parent peer as a liaison to communicate with and support parents throughout the process. So that's that parent peer liaison that we talked about in the model components. And Match should leverage care connectors to provide ongoing and intensive case management for abandonment referrals and coordinate with Medicaid or a private insurer. Match should also continue to take referrals for any child who is at risk of psychiatric lockout. This would include children with private insurance. And as I said earlier, Match is currently taking these children as underinsured. DCH should ensure that private insurers and Medicaid cover and expeditiously authorize all necessary services. And examples are prevention, family, and post-discharge services that are needed to prevent psychiatric lockout and maintain the child in the home post-discharge. DCH should also leverage state plan amendments, waivers, EPSDT, managed care value-added service arrangements, or in lieu of services. DCH should increase Medicaid payments for facilities and intensive community-based and in-home services, and make sure to hold PRTFs and community providers accountable for quality treatment and discharge planning through data reporting and monitoring. And DCH should ensure that CMOs are held accountable for quality care management, access to services, which includes authorization for an adequate amount of treatment, and outcomes through data reporting and monitoring. DFACS should ensure that parents and guardians are aware of the voluntary placement agreements to receive additional services without relinquishing custody. DFACS should expand Title IV prevention plan services to include more diverse, intensive, evidence-based programming for children at imminent risk of foster care, and ensure these programs are structured to qualify for Title E funding. So these are some of the services that Match mentioned as their pilot services, which are Intercept, IC3, High Fidelity Wraparound. I can give you a whole list if you want it. Department of Education should ensure that schools are meaningfully partnering with parents via IEPs, 504 plans, school-based behavioral health programs, and other supports to maintain a child with high mental health needs in schools and prevent crisis and out-of-home placements. DOE should leverage school social workers to support families through screening and referrals to healthcare and social supports. And last, the state legislature should ensure funding to support match case management and services and direct Georgia employers to provide adequate paid and unpaid sick leave so that working parents can help their families get and stay physically and mentally well. Thank you so much. And I'm happy to take any questions.
Okay. Representative Cameron.
Thank you for your testimony. Under your recommendation of DCH, ensure that private insurers and Medicaid cover and expeditiously authorize all services. You saying we should mandate that, like the legislature mandate? Or require?
Yes, so I believe that DCH actually signs the contracts. I think that's something that could be worked out in a contract, but I could double check that and be sure.
Okay, and then under state legislature, direct Georgia employers to provide adequate paid, unpaid sick leave. What would be adequate? I mean,
So that's hard to say,
Yeah,
obviously, because we've seen the time range that these children can be in there. I think that probably something that's equivalent to FMLA. And I believe that I would have to check on the
That's
exact
fine.
amount of time, but that would probably be an appropriate starting point.
thank you, Madam Chairman.
Chairman Cooper.
Okay, do we have in our state the voluntary placement agreements?
Yes, we do. It's my understanding that those really aren't being used that frequently, but in looking at creative solutions, I thought that might be a way to buy some parents a little more time and avoid the kind of custody and treatment debacle while they're preparing to take their kids back into the home.
Right. Okay.
Representative Crawford.
Thank you, and thank you for your testimony. Earlier, you spoke about psychiatric lockout and making sure that there's early detection or whether or not it's imminent. My question is, as you are trying to confirm whether or not that's going to occur, what, if anything, are you doing to confirm that?
So I think the providers spoke about this to some extent, and really we did speak with some providers when I prepared this presentation, and they say you can tell immediately when this is going to happen. And you know, a lot of times these kids are returning. A lot of times the providers are familiar with the family, so they say you just know. And I think it would really be up to the providers to make the decision or make the determination when something is imminent, but it sounds like they usually have a pretty clear idea, and that would be the point at which they would go ahead and contact Match and let them know that that's coming down the pipeline. Did that answer your question?
Yes, slightly. And I guess the next question from your response is what has been done, and if anything, to try and maybe convince guardians not to abandon?
Yeah, and I think that's all kind of part of right when the child starts their treatment. I think that's all part of the services and the therapy and the peer support that starts getting put in place immediately. So I think that all of those services are there to mitigate and try to prevent psychiatric lockout, and just that they're getting the parents prepared while the child is in treatment. So I don't know if there's any perfect criteria or perfect prescription, but I do think a lot of those services that we mentioned, those parallel services, can really help mitigate any kind of psychiatric lockout.
Thank you.
You're welcome.
Any other questions or comments from the committee? Got one. I just wanted to ask you, when you did the slide where you spoke about the two programs, Illinois and Washington.
Yes.
And you listed the specialized family support program. And I believe, I want to make sure I heard you say that ultimately in the end, the parent is responsible. Tell me how that works. How do you make a parent who's abandoned be responsible for the
Right. Right. So I think that kind of goes along with it being a voluntary agreement. Because I did speak to some people in Illinois. There was one person I was unable to speak to who probably could have answered that question. But it's my understanding that that the parents, that insurance, Medicaid, waivers, things like that do cover a lot of this. I think that they just, at the end of the day, it is an agreement between the parents and the child. And I think that that if the parent wants to be in the program, ultimately they have to be responsible for any uncovered costs. Now, I don't know how much of those costs the parent is actually absorbing. I would be happy to continue to try to contact the person in Illinois and see how that's working.
Yeah, I like it, but most of what we're talking about here are parents who really don't want to be involved anymore. So
Right.
I mean, when they've said, we're out,
Right.
then
Well,
what?
Yes. Oh, pardon me. I'm sorry to interrupt you, but this is the specialized family support program would kick in while the child was still in treatment.
Okay.
So I think its main purpose is really try to prevent
Okay.
psychiatric lockout and not try to kind of get it from the back end after the parents have already said absolutely not.
But if they're in that program and they step out, so when you're going to talk to this person, that's what I'd be interested in. Like, what happens then? Where does the money come from? If they're in there and they're saying, you know what, we've tried, but we can't do it. We
Yeah.
can't.
I can certainly find that out for
Yeah.
you.
That would be good to know. Yeah. I don't see any other questions.
Okay. Thank you so much.
Thank you. Good information. Appreciate it. And we've got a little more information on those two here as well. So moving right along here, the Emory Barton Child Law and Policy Center, Miss Melissa Carter, Executive Director. Good to see you. Good to see you. Good to have you here to enlighten us some.
Madam Chair, good afternoon, members of the committee. Yes, my name is Melissa Carter. I'm the Executive Director of the Barton Child Law and Policy Center. For those of you who don't know, I hope you will know the Barton Center soon. For 25 years, we've tried to support the members of the General Assembly with research and data and evidence and our expertise in the fields of child welfare and youth justice. We also provide public education and professional training, and we do deliver legal representation to youth and parents involved in juvenile court proceedings. But prior to my assuming this role 15 years ago, I had spent most of my career in Georgia state government, and I had the privilege to serve the Office of the Child Advocate, providing oversight to our state's child welfare system. And I also served in capacities representing caregivers and youth as an adoption practitioner and in juvenile court proceedings. And I also spent some time prior to that in another state as a case manager working for public child welfare. And it's really those prior experiences and roles that I bring expertise and a viewpoint to you today. And I will say that my opinions and perspectives that I bring to you don't represent my current employer. I need to sort of stress that as I testified before you today. I'm really grateful for your attention to this issue today, really for your compassion, even from your opening remarks, Chair Dempsey, and for your time and your patience, and just really the way that you're engaging with all of these issues. And I appreciate being invited to present to you today some information on the rights of children in the child welfare system, and I'll try to be economical and fill in some gaps given all of the great presentations and expertise that you've heard today. So I think you've got my slides up before you today. You do have a familiar profile. You've heard a lot today, so I won't belabor the point. I think it's important, though, to share with you and to really invite everyone to think about this from a little bit of a wider lens, that the children that we're talking about today, really in terms of the profile, thinking about the age and the behavioral concerns and the way that they present to us in our systems and to us as legal practitioners or advocates throughout our system, are the same youth that we see when we're talking about other issues that you all have tackled underneath this dome and that we see in other spaces in our child welfare system when we talk about hoteling. when you're talking about other issues like children in need of services. And even when you're making decisions about, I think in the medical community, we talk about high flyers maybe, or frequent flyers in our medical system, or even when you're making decisions about policies regarding children who've committed crimes in intrafamilial circumstances or even committed crimes in the broader community. These are kids who have these kinds of challenges. And are presenting in different ways. So the contributions that are being made here are really facilitating solutions in other areas too. And I think it's really important to acknowledge that we're doing service and doing work in a lot of different areas. That this is an overlapping profile. And I think it's easy to see that these histories of trauma that are prevalent for these kids and the kind of multiple system involvement and the behavioral challenges and the non-compliance are something that we see in profile in lots of different other conversations. And that this profile of youth who is abandoned at discharge from hospital settings, and this youth who is at risk of harm to self or others to a degree that's going to overwhelm parental capacity, and who is likely to need rehospitalization and may even be arrested within weeks or days of discharge and re-traumatized in that process, is going to enter a system, at least in the context of our mental health lens that we're taking today, that is also familiar in profile, one that is characterized by a shortage of specialized mental health services, where we know we lack child and adolescent psychiatrists and other mental health professionals to the degree that we need them. We lack residential treatment facilities for children, where we may have short-term crisis stabilization, but not long-term residential treatment, where we have fragmented systems of care that are not well coordinated and don't communicate well across systems, where we have inadequate funding for mental health services, notwithstanding recent investments. You've heard a lot about the processes that we have built and where we have investments in system navigation, but where we still lack the resources for placement and services that we need, at least to the degree that we need them for the youth that we're talking about here, and where the cost for those things are certainly exorbitant and prohibitive in terms of access. And importantly then, that these systemic problems are really impossible for any individual clinicians, whether those be healthcare providers or the case management, the sort of child welfare field practitioners that we're talking about, or the ethicists or the parents to really solve, particularly at a level of a child in front of them with an urgent unmet need. And so there really aren't bad actors here. I want to really stress that. We know the children aren't bad actors, neither are any of the professionals. I sit here so privileged to know many of the people who've testified in front of you, to know many of you, sometimes for many years, sometimes for decades. I've served children who've sat in these placement providers, who've received services from these folks. I've learned from everyone in this room. And I know how talented our field is and how committed we all are to making sure children are getting what they need and we improve outcomes and keep learning and adapting our systems to do better. And this is one of those really wicked problems that we're here to tackle. And I, again, appreciate the attention that we're giving it this issue today and will continue to. But that problem becomes really more pressurized, as we've talked about and heard in the testimony today, when that child enters care, sometimes unexpectedly, often while at a crisis stabilization unit, maybe following a 1013 commitment or from a PRTF. That child may be ready for discharge, and the parent, as we have talking about, refuses to pick him or her up, and or the insurer, who is often the Medicaid CMO, has determined the child is no longer eligible for covered placement at that facility. That child's behaviors may still be violent or disruptive, so DFACS then is scrambling for placement. The options are limited. The options include retaining that child at the PRTF, at this point using state funding because the child no longer meets criteria for medical necessity, or placing that child in a hotel, again, using state dollars, and of course, that's far from desirable. DFACS could also place that child with a non-contracted provider. That means that federal reimbursement would no longer be available, and we're using non-standard rates, also very expensive. Or as the Senate Budget and Evaluation Office observes here, we can find an alternative placement option. I think that's where a lot of the attention then shifts to the pressure on the parent as we're talking about here. This is when practitioners like me get calls from parents or people assisting parents saying, as it's been often put, that DFACS is threatening the parent with a charge of abandonment, right? We're threatening them with abandonment as it's been put to me. To be clear, Although we've heard differently here that sometimes law enforcement says they may charge a parent with abandonment, I've never known a case where a parent is prosecuted with abandonment under these circumstances. Clearly, what we're talking about here is a shift in responsibility. Under very difficult circumstances where DFACS nor the parent is able to purchase services or navigate services where services don't exist. And so no one's able to solve the problem for a child who is confronted with these very desperate circumstances. And so here we are in this context and conversation about abandonment. So as someone who's invited here to talk to you about some of the legal context, for context, here are, and I understand you've been provided with a handout, so these things may overlap. But for purposes of context setting in this conversation, here are some legal definitions of abandonment under our state law. In our private domestic relations code, here is our legal definition of abandonment. We talk in terms of a father or mother placing a child in a dependent condition by failing to provide that child with sufficient food, clothing, or shelter, and doing so would be punishable as a misdemeanor under most circumstances. But really, in the context of the fact patterns that we're talking about today, we're really dealing with our definitions under our juvenile code most likely. So our legal definitions under our juvenile code really speak in terms of foregoing parental duties or relinquishing parental claims. Under the fact patterns, again, that are now readily available to you, I would say that reasonable minds may differ about the interpretation of the juvenile code's definition of this term abandonment and whether any given parent under any given set of facts is intending or evidencing an intent to forego parental duties. Certainly, we can imagine easily that they're exasperated. We don't know at any given point whether any person is intending to forego parental duties. What we do know is that if that case proceeds to court, a parent might find that that child is in fact dependent on the state. You can see the definitions here that under our juvenile code, a dependent child does include a child who is without his or her parent, guardian, or legal custodian. I've also included for you the definition of neglect, which includes the failure to provide necessary parental care or control, and you can read on for yourself, and includes also the abandonment of a child by his or her parent, guardian, or legal custodian, then incorporating the definition we just talked about. So certainly, descriptively, if a parent refuses to claim a child at the point of discharge from a hospital, the child is without a parent, guardian, or legal custodian, and maybe at that point neglected and therefore dependent, just in terms of adding up the syllogism. So I will say I would absolutely co-sign all of the commitment that you've heard stressed here and the policy of this state and of this country and U.S. family law that children belong with their families. That is absolutely true. That is undisputed. It's certainly my values as well. And I would agree with everything that Ms. Carroll said earlier in terms of what the U.S. Supreme Court has said. Parents do have a constitutional, fundamental, in fact, right to raise their children, the right to the care, custody, control, maintenance of the relationship of their child. The U.S. Supreme Court has said that is one of the most well-established and oldest of our fundamental rights. The problem is, and the reason that our child welfare agency, DFACS in this state and every state, feels the pressure and the responsibility, and in fact, the burden that they feel is because that fundamental right is in tension with the compelling interest of the state in child protection. The state also has a fundamental duty to protect children. It's called the parens patriae duty of the state. So where a child is in a dependent condition, the state has to step in and protect that child. Those two things coexist. There's tension between them. That's the complete legal analysis. And so, for example, or as we continue to talk about the sort of dependency scheme in our state, once we get to a question or analysis about the state and its inquiry into the dependent state of a child, it's not about the parent's fault. It's about the child's circumstances. And so if a parent says, I'm out, we'll have a different conversation about their intention and whether they should be held criminally responsible. But at that time, the only thing the state is concerned about and what triggers the state's duty to protect that child is the fact of the state's dependence, the child's dependence. The fact that the child does not have a parent or guardian, the fact that the child doesn't have a custodian who is able to make decisions on behalf of that child. You've heard a lot from our providers about they need someone to be able to make legal decisions about the child's treatment. And of course, we need someone to make decisions about where the child's going to live. That's what custody is about, right? Physical custody and legal custody. And so that's what we're looking for, and that's what we're concerned about. A decision maker, a custodian on behalf of the child. So if that debate is settled in favor of the child entering custody and being placed in foster care, that triggers additional rights on behalf of the child. Much of the time, when we talk about children's rights in this gold dome or under this gold dome and in other contexts in the public forum, we're talking about largely aspirational rights, those kind of fundamental entitlements that are ideals, but may not be fully guaranteed or immediately enforceable in every legal system. Most of our child welfare rights are those kinds of aspirational rights that are positive in character. The state must take action and provide resources to achieve safety, permanency, and well-being. But while those kinds of things might generally be considered important for a child's development and a reflection on the state's duty to provide care for that child in state custody, they're not what we call justiciable. They're not those kinds of things that have remedies that are enforceable by the courts. And that's because we're in this federalist kind of context where really our child welfare system is the resultant product of this state-federal partnership where the federal government sets these broad federal policy aims and the state has discretion to implement programs and make decisions and do case management and provide services that satisfy those standards. And so there aren't really those kinds of enforceable rights that come from that. There are just these broad standards and outcomes. Now, we've codified those rights at a state level, but again, it's not the kind of thing that if little Johnny doesn't get to be placed with his sibling, which is a right that a child has, that there's any particular enforceable consequence to that, if you will. For example, so children's rights really have two sources. There are some constitutional rights that children have, and there are a set of complex kind of federal and state statutory rights that are largely of this kind of aspirational or positive rights kind of character. Those constitutional due process rights that expose the state to some liability when we fail to meet them are what some scholars, and I think it's fair to call them dependency rights. There are essentially two categories of them. There's a general right to be free from harm. So the state has a duty to ensure the child's reasonable safety when the child is in foster care and provide him or her with adequate care and treatment while the child's in foster care. The specific rights that hang off of that are still kind of established in different ways. And they generally would include that right to adequate food, clothing, shelter, as you might guess, medical care, a freedom from physical, emotional, and psychological harm. In some jurisdictions, courts have found that they include specific rights to safe placement and supervision and adequate services. So you do get into this arena of treatment services under that broad dependency right that is a right to safety. Courts, including courts in Georgia, have found that the state also has a duty to assist a child in the exercise of this right to family integrity. That's really about maintaining the right to the relationship to the child's parents and also sometimes the right to siblings. Some courts have found that extends also to extended family, at least a nuclear family that might have had some custodial relationship to the child. So again, that's part of that right to family integrity. So when a state fails to exercise some degree of professional judgment to fulfill those duties, you may have some liability in a constitutional sense. If you've heard of Kenny A, that governs our child welfare system in Fulton and DeKalb counties, it's rooted in some of these dependency rights in our 14th Amendment due process. So that's the constitutional, right, in a nutshell, basis for children's rights. In the context that you're talking about today, some of it overlaps, but really these might interest you more. These are some select kind of high-level healthcare rights There are, of course, other expectations, rights, if you will, in air quotes, that are set by policy, particularly rights that are set out in more detail and practice guidance that are set out like in DFACS policy and other regulatory and sub-regulatory guidance. The federal law, the Fostering Connections to Success and Increasing Adoptions Act in 2008 is probably the most comprehensive statement around healthcare rights for children in foster care. It details some specific rights that are provided or should be set out in individualized transition plans for particularly emancipating youth, so older youth who are going to exit foster care. They have to have individualized, personalized transition plans that include a whole lot of detail that are going to help them then launch into self-sufficiency as adults. Of course, it must address health insurance, among other things like housing and education and things set out for you here. The youth must also be provided with options to execute healthcare powers of attorney, healthcare proxies, or similar documents. Again, all those things that set you up for security as an adult. At a systems level, DFACS must have a plan for ongoing oversight and coordination of healthcare services that has to include a lot of features, including how the department works with professionals in the mental health and dental and pediatric worlds to inform their guidance for how children should develop well and have all the kinds of well checks and other kinds of guidance around healthcare healthy development, screenings, et cetera. It encourages the development of an electronic health record and medical home. It requires and puts great emphasis on oversight of prescription medicines, particularly psychotropic medications. You've done some legislative work here in years past to codify these requirements. This law has been amended recently by a recent law passed by Congress to require informed consent of youth and then further consultation with other professionals. We've had some questions already. I think Chair Dempsey, you raised this at the very outset around the Family First Prevention Services Act. Of course, this is a new opportunity, relatively new, passed in 2018, but we're still working to implement it in this state and across the country that creates an option for the state to expand access to evidence-based services, including mental health and substance abuse prevention and treatment services to prevent unnecessary placements of youth in foster care. And so this is another opportunity for the state to move into that early intervention and prevention space. Beyond child welfare laws, if you will, of course, we have opportunities in the Medicaid arena as well. Again, these are select, specifically with respect to the Medicaid Act. Of course, all children in foster care are categorically eligible for Medicaid, and that includes then access to a full complement of comprehensive, continuous, and trauma-informed health care, medical, dental, mental health, and vision. You've heard probably a lot over time about the Early and Periodic Screening, Diagnosis, and Treatment Act, EPSDT, that creates specific mandates for children under the age of 21, including regular well child exams, developmental and behavioral assessments, dental care, immunizations, and importantly here, any treatment as excerpted in quotes for you, necessary to correct or ameliorate health conditions. And that's really where you see some elasticity in the law about what that mandate will cover. And then under the Affordable Care Act, a specific entitlement for youth aging out of care to access Medicaid until age 26. So those are some specific provisions around legal rights to address health care for children in this arena. We've had some great recommendations brought to you today. There's really no reason for me to say any of those are worth any, those are all worth your support for sure. I in no way mean to compete with any of those. Those are probably worth most of your attention, but some things that have come across my desk that I've had some occasion to support or inform over time that I wanted to bring forward. There have been some efforts in recent years and now, and I'm sure the Department of Community Health can talk about this in the most informed and current way, around therapeutic foster care. I don't even know that it's continuing to go by that name, but therapeutic foster care has really been an area of some demand, if I can use that word, from the child welfare and child advocacy community for some time. This tracks back to, I I think in like 06, 07, some of you might remember there was the unbundling of Medicaid where therapeutic and placement services had to be separated and from a billing code standpoint. And because of that, we lost some of the integrated services that we previously had in our continuum in child welfare. And so we lost then some opportunity for therapeutic foster care that had previously existed. And ever since then, there's been sort of an appetite to recreate that. And I think it was around 2000, there was an effort to create therapeutic foster care, and CMS denied it. And then there's been an effort recently to repackage that in a broader sense and get that approved. And again, I don't know the current efforts. I was allowed to provide or invited to provide some input on the design of that, but I don't know the current status. But again, something that's needed and I think would go a really long way to creating these kind of, in that broad menu of step down services, the kinds of things that would allow us to have an intervention before we get to the hospitalization that could meet a lot of needs, or step children down out of hospitalization so that when they're ready for discharge, we have somewhere to put them before bringing them home and causing that aggressive cycling could be very helpful. And so that's one that I would ask go on your list maybe for further consideration and exploration. Likewise, continued exploration of the expansion or implementation of community-based services. When I have been involved in individual cases or the consultation of cases, the denials that I have seen from the CMO often talk about the need to exhaust other community-based options, many of which we don't even have. And so that's certainly kind of frustrating. And currently, Georgia is the subject of a lawsuit, the Isaac A. case, which was filed in January of 2024. So the North District of Georgia is currently deciding whether at least these current services are in fact rights of children that have been denied. But whether it's these specific ones or ones that approximate these, the idea that we need more intensive interventions for youth that can speak to these emotional and, kind of behavioral dysregulations beyond the institutional interventions that we've invested in, I think are worthy of exploration. Dr. Doyle and others have talked about the step-down capacity and transitions, these least restrictive options. Least restrictive options are rights of children. And again, there are others who have more expertise and vocabulary around the specific programmatic and service menu, but least restrictive options are the way that we as lawyers talk about it. Those are constitutional and statutory rights of children. So there are, that's the association I would make in the opportunity that I have to talk to you today. And then lastly, again, to circle back to the Family First Prevention Services Act, again, evidence-based mental health, substance abuse prevention and treatment, skills-based parenting that is in the home for candidates for foster care is the terminology in the federal law, and their caregivers. So an opportunity for a two-gen approach here to have interventions, effective interventions for children who are at imminent risk of entering foster care and their caregivers, which can be provided for 1 year and renewed without limits, provided there's a justification in the child's prevention plan. We've had a limited rollout of this. We do have a federally approved plan, but we don't yet have a federal drawdown. Most states have not drawn down federal funding. So there's just an opportunity here, I think, to square our shoulders at this and really see if this can't be some catalyst for real change to get more interventions on the ground. For us in Georgia, because you as a legislature have made such tremendous investments in juvenile justice reform, where you now have evidence-based interventions in every judicial circuit, that's the same menu of services that are authorized under Family First. There's a real opportunity for some braided funding and some work to dovetail those together and really create then a platform for serving children and families in the community across these otherwise siloed systems that I think could be a game changer and really address then what Commissioner Brose addressed in this letter to the editor and that you all have observed as well, that the untreated mental health conditions of biological parents, again, 2gen, and ensuring the availability of lasting pathways of mental health support following initial juvenile justice involvement, taking us back to that profile that is common across the policy conversations that you all are having and the practice conversations and the kids and families that we're all seeing, in our work on a daily basis. So that, I hope, is somewhat helpful to all of you. We certainly are committed at the Barton Center to being helpful to you in this conversation and on an ongoing basis. You know how to reach us, and so that's certainly an open invitation. Thank you.
Thank you. Great information. We'll start with Representative Cameron.
Thank you for your testimony. I have it's a little bit of a different kind of question. I'm wondering, I have high absence rates in my school systems. I mean, one of them is 27%. I'm wondering how that fits into students end up getting in the mental health system because there's no structure at home. So they just wander and they end up either in trouble or they end up,
Yeah, I think, out of respect, what I'd say at one level is there's probably, clinically trained people who could give me a really good answer to that question. But I think from my perspective, I think there's a lot of I guess go back to that common profile. I think at one level, risk factors are all the same. And those, truancy and absenteeism from school is an indication of instability in the home. I think that's probably where your question is coming from. Those low level risks suggest something about high need. Low risk, high need are the early pre-intervention moments. And that if we can have some intervention, those early intervention opportunities, that's a prevention of the next level, right? So I think those are the kinds of things that we can that we should be thinking about as we build out the system, and that those investments are worthwhile so we don't get a deeper end, presentation of symptoms and more costly in every way, human costs and actual dollars costs problem. Yeah.
Thank you, Madam Chair.
Thank you. Chairman Cooper.
Thank you, Ms. Carter. Interesting presentation. You made me very sure of the fact that I chose the right late in life career path and didn't go to law school.
You've been great. You've been great.
My sister, who was a lawyer, convinced me of that with many phone calls from Texas saying, don't do it.
Don't do it.
So, okay. So I'm trying to think if I know how to ask this question. It seems like to me that the definition of abandonment was so important. Would it be to start with that so that it would include the possibility of all these wraparound services that we need in some way in our definition of abandonment? And do we need to pull this out? Sometimes we pull pieces of law could have gone in another part of the law, but they're for elderly, so we put them in a specific area. I mean, is there some way that we need to start at the very beginning with that part of an abandonment is causing a lot of our problems of getting mental health things covered?
I think it's about what you intend for the law to accomplish, right? So in our juvenile code, my point is that the juvenile code is about figuring out focused on the needs of the child. And it's this tension between parental responsibility and somewhat accountability and the needs of the child, right? And in there is also state responsibility. And so we're trying to balance all of that out. Different from in the criminal code, we're thinking about what is the accountability of the parent, right? If we're in the abandonment conversation, and should we punish? Criminal code is very much about, are we punishing the parent, right? Holding them criminally responsible. That's different from other things, right? And you can think about torts and contracts and other things that I don't even want to think about, right? And so it's really a question of that. And so I don't know that I'm a little bit biased in that I helped you all write the juvenile code.
Right.
I think we've struck the right balance. I think we've talked very carefully and thoughtfully about the purpose of our juvenile code, and we've designed it and been very explicit about all of those responsibilities. In the juvenile code, it's always going to be child, parent, state. That's what the juvenile code is about. And so we've said that. We've said the parent has a responsibility for protection, education, and support. And where the parent is unable or unwilling to do that, the state has a duty of protection. And the child is in the mix there in terms of the recipient of those two things. I start out by sharing with you briefly my background. I am very much a proponent and supporter of public child welfare. I've been a part of that my entire career. I understand fully and have been responsible for cases as a case manager. It is an impossible, you've heard, it's impossible. You can imagine being the person who's assigned that case. DFACS is in some ways a consumer of, in the same way, DFACS is the parent, right? When a child comes into state custody, DFACS is acting as parent. And they are no more able to conjure new resources than the parent is. They are no more able to navigate state resources that don't exist than a parent would be. So of course, they are as exasperated, as burdened, as, frustrated as any parent would be, but they don't have anybody to surrender the child to, right? They are ultimately responsible, and they carry high expectations of the public. And they carry, again, all of the responsibility. If the state cannot provide the infrastructure, the mental health system infrastructure, the behavioral health infrastructure, DFACS has nowhere to go to purchase or access the services to meet the responsibility that they have as parents to achieve the outcomes that they are responsible for achieving for the children in state custody. And so that ultimately, I think the only thing that we can do here is work on structuring that part of the missing piece of our system.
Well, then, is it okay? Then is it okay? Do we need to reword the part about abandonment, or the definition of abandonment a little bit? And that of, because I don't want the parents to be punished either, because I've had these people call me when they've reached their, the end of their ability to handle things. Some way to use the involuntary release of parental rights for a temporary time, so that we don't have these children caught in this no man's land of, that what happens now, and they can't give them the treatment they need or whatever. How do we do that?
Leslie mentioned the voluntary placement agreement. I think that's worth a conversation. Voluntary placement agreements have been authorized by the federal government really for decades. We've had them on our books and authorized by our policy, our child welfare policy, for the same amount of time. They've fallen out of disuse in Georgia for a very long time. We use them in a very limited circumstance for youth who are re-entering foster care beyond age 18. I think it's worth a conversation in this context, so that we don't create that impossible tension of either you forego parental duties when you don't really mean to and we don't really want you to, or we threaten you with abandonment, right? And that we create bad guys in a circumstance when that's not really what is happening. Because I don't think that's productive. So maybe that's the answer. Again, I think I would just implore you, even though I know this is an unpopular thing, to really consider what resources do we have to invest in creating more options. In addition to thinking about what mechanics do we have at a policy level to diffuse the tensions that we are artificially creating between the various actors that we have here.
Well, I think you're right. I think we need to diffuse that problem. And we're trying to diffuse the other one by, getting more social workers and so forth, but it's a long-term thing.
Yeah, right.
And in the building, even if we opened the pocketbook and paid for a lot of things, we don't have people to staff it.
Right.
For adults to look at those kind of things.
Right.
Well, if you think it's worth, if the chairman should think it's worth, we look at that, maybe you could help us talk about
I'm
that
happy to.
later, if she thinks it fits in this,
Be
because
happy to.
I don't know what we're doing.
Crowdsourcing, we're brainstorming.
Thank you. We're listening.
Yeah.
We're learning. That's what we're doing. We're here. Thank you.
Yeah.
Wonderful information.
Good.
Thank you, Chairman Cooper. As always, you've cut right to where I want us to try to get to too, because I do think the word as it is defined in code right now is the hiccup in the 6-month pause that keeps a child without.
Yeah.
And I think we've got to figure out, is this the only unique situation where that happens? Are there others? What else? Because I don't want us to, if we are going in to change something that big, I want it to be where we can change it and not hurt anything else, but certainly have some real validity to going forward, some fidelity built into it that helps wherever it may be needed. And I know you know a lot about that.
Well, lawyers
So-
love precise language.
Well,
So
we're
we
looking
can
for that.
figure out what word has the most integrity to describe and achieve what we're doing.
Looking for that. So I want to ask you to go and particularly to work on that. And I want to just say too, I know I'm familiar with how much 2Gen work we are doing here
Yeah.
through Decal
Yeah.
and through the Children's Cabinet, both of those. We may need some of that information that you may be aware of, though, to add into this committee information. So if you have anything from what other states may be doing, some advice, particularly with family first prevention.
Yeah.
Some other things that you think we need to know,
Great.
feel free to send them our way.
Great. I'd be happy to. I had the privilege to work in a handful of states around Family First, so
Good.
hopefully that'll be helpful. Yeah,
Good.
great.
Thank you. It's great
Thank
to
you.
see you. Appreciate all the work you're doing.
Very much appreciate it.
Mhm. All right. So we have one more. Now, hang on. We're doing good. The Department of Community Health. Stuart Portman, the Executive Director for the Medical Assistance Plans Division. Stuart, everybody may not know you. I want you both to introduce yourself while you're here and tell us a little bit about you and then help us get a little bit smarter. Okay?
Thank you. Appreciate it, Chair Dempsey, and to all the members. My name is Stuart Portman. As stated, I'm the Executive Director of the Medical Assistance Plans Division for the Department of Community Health. So the Medicaid Director for the state. I'm joined by Joe Hood, the Chief Operating Officer for the Department of Community Health. And appreciate the opportunity to share just a moment of my own background and interest. I came to the Department of Community Health and the state of Georgia in February of 2024. Before that, spent about a decade working in the U.S. Senate, about 6.5 to 7 years of that as the Medicaid and CHIP policy lead for the Senate Committee on Finance, representing the various chairmen and ranking members on the GOP side for all issues related to Medicaid and CHIP. So, before that, started with Senator Orrin Hatch of Utah as his health advisor. So come to this role with a lot of federal Medicaid experience and a variety of different issues. And I'm grateful for the opportunities here in the state. So happy to jump right in. Today, and I know we are the last of 7 presentations, but appreciated all the comments from the others as we've been watching and paying attention, and really remain committed in the same way to trying to advance forward in this space, and are excited to speak to you today about an in lieu of service in the Medicaid program, and I'll define that for everyone, and the specific creation of a new model called the Community Sustainability Model. So to just give a little bit of an overview, I want to make sure everyone understands what an in lieu of service is in the Medicaid program. Most benefits that exist in the Medicaid program exist in the state plan, the Medicaid state plan. Frequently, we submit state plan amendments to amend the benefits within the state plan. There are also waivers. They can be demonstration waivers of different types to also, act in the absence of the state plan. However, within managed care, and specifically within the care management organizations in the state, there is the ability to offer an in lieu of service, which is a pathway of financing that allows the plan to optionally choose to cover services that are covered in lieu of a state plan covered service. It is an option that many states have availed themselves of. Georgia historically has not. And so there is some managed care regulations from the federal government that came down in 2023 that cap the amount that can be spent at 5% of your total managed care expenditures. Some states have a concern about that. We weren't doing it. So we have the ability to take advantage of that opportunity to look into this financing mechanism. Of important note, it has to be optional for the plan to participate. And then the entities that work in this program are contracted by the plan. But excitingly, all 3 of our plans that operate in our current contract for care management organizations have signed contracts to participate in this model. And we already have that. It is with CMS. And I will go into that in a bit more detail here. So as I sort of define this community sustainability model and go into the various parameters that it has, the purpose, first and foremost, is to address the youth that are at high risk of or already being abandoned. The focus of this is to try to get on the front end, try to act as in a preventative way as much as possible, but also make sure we're opening up the offerings that could exist for those that are already in a placement that is creating risk. So while the estimates can vary in terms of the number of children affected, I know there's been different numbers provided today. The family strain is growing. We know that in the state. We know the case complexity is growing. And I'll share a little bit of a case example towards the end here. But this specific proposal has 5 in lieu of service offerings that are combined into one model. And that's important from the DCH side because each offering has to be its own standalone optional item. And as I mentioned, all 3 CMOs have agreed to participate, and all 3 CMOs have agreed to participate in all 5 of the components of the model. However, one last note, the model has, while the benefits are in lieu of a state plan benefit, meaning CMS, as our federal regulator, does not have to approve the program, they still have to review the proposal as it relates to any impact on the rates. So the proposal is currently sitting with CMS, but it has been agreed to by all parties in the state. The goal of this model is really to help those young people experience life and treatment in their home or in the community and not in a residential placement whenever possible. It's also designed uniquely, and this really gets at the heart of a lot that was mentioned today, to ensure that the caregivers themselves have treatment capacity, confidence, and the competence to assist with that broader goal. We have 2 sort of broader components, a service component, which is really comprehensive and multi-generational, high-need discharge and wraparound services, really intended for members as they exit facilities, whether it is a PRTF, a CSU, or an emergency department. And the emergency department piece does play a role here too, given the issues related to inpatient boarding or emergency department boarding that we know exist in the community here. Additionally, there's a placement component that includes one of 3 settings where the services can be delivered and intended to be delivered in as flexible a manner as possible. Those would be the member's home, the member's family home, and the family is broadly defined because that will also include foster youth, a respite stay at a PRTF, or some home-like setting in the community that is not the family home. Every one of the components of the model has to include a comprehensive family needs and reunification assessment and plan. The point of this is really to be able to move through the system in a way that is meaningful and actually focused on treatment. And that is something that we have heard loud and clear at DCH. We've talked to our sister agencies. We've worked close in coordination with our sister agencies to make sure that we understand the importance of having that assessment and that plan that have to be triggered when a CMO is aware that a member is or could be stranded in a residential setting. So ideally, we're starting this before the discharge date, and not just adding on to a discharge. But that will be part of our oversight opportunities to make sure that this is being implemented effectively. But if the member is in an emergency department, we would want to make sure that that assessment and needs assessment is completed prior to the member discharging to the placement as part of the model. Every CMO will have a case management team that has to complete that assessment and plan for the appropriateness of each of those components. And as part of this model, we actually are funding a social worker case manager for each of the plans to actually ensure that the enhanced case management is being provided. So by participating, there is an added benefit of making sure that there actually is that social worker case manager to assist in all of that case planning. So as stated, all 5 of the in lieu of services are already included in the rates and already included as supported by the 3 CMOs. And there'll be an additional case management requirement for Georgia Families 360, which means additional caseworker as well compared to the base amount for the Georgia Families program, which is the base contract in our Medicaid program for managed care. So I'm going to go through each of the 5 different components so that everyone understands them. I'll try not to read off the screen, but there are important benefits. And it's worth everyone knowing that first and foremost, there's an assessment bed piece, which is trying to prevent the initial placement, which we know sometimes happens out of good intentions, but desperation. And so this is trying to get to that 30 days pre-placement, but post emergency department or CSU. So this would include what we're calling temporary braided step-down setting funding to help with the stay, psychiatric diagnostic assessment and diagnosis history review, medication management, individual and group treatment, and all non-clinical activities that would need to be included. And it would include, as mentioned, the CSM assessment and treatment planning portion for both the member and the caregiver. It has to be conducted by the CMO case manager at the facility in preparation for discharge to either the community setting or home, or if they're going to another component of the CSM. So this is on the front end of a discharge. The second, and this is the goal through all of this, is a program with home supports for youth with serious behavioral needs. And this is the full range of benefits, which is that high quality planning, assessment and planning. There has to be leadership level care management and supervision from the CMO. There has to be ad hoc respite care for the caregivers of the member. There has to be a family coordinator to be a liaison between the family, leadership of the CMO and the community, as well as leadership from any of the organizations involved in that care plan. A behavioral aid service that can support ASD and mental health needs, and in-home capacity to treat the behavioral health needs of that member. And that list includes trauma treatment capacity, in-home rehab care, such as OT, PT, ST, depending on the needs of the member, in-home substance abuse services, depending on the needs of the member, evidence-based intensive in-home services, in-home psychiatry, in-home nursing, 24-hour crisis management, a new component, intensive parent peer supports, which would allow for those CPS providers to spend more time with guardians and actually focus on coaching and building up the necessary skills and experience to allow for a more successful transition home. And caregiver therapy, specifically to address the caregiver's fears, anxieties, and traumas. So it's not family therapy as noted in the presentation, and is intended to just be for the caregiver, knowing that they need to be at a point to bring that child back into their home, that they can have the confidence necessary for it to be successful. And if needed, there would be some reintegration supports and physical environment modifications. So that is the goal, is that if there is someone who has to be a part of this model, they are home receiving this full range of benefits and services. However, we also recognize the reality on the ground, and sometimes it might take a couple of steps to get to this point. And so we would also be using an in lieu of service to cover an up to 30-day respite stay at the PRTF when discharge has been deemed appropriate, but the discharge itself is proving challenging, to get at the concern that there's perhaps not the necessary group aligned in trying to help with that discharge, make sure that there is some coverage for the setting and medication management, individual and group treatment, and all additional non-clinical activities, plus that assessment and planning, bringing all those things together at a rate that is lower than the PRTF stay, but in recognition of this is where the child is at that point in time, as a way to say that we need to make sure that there is a focus on getting them out, but we're paying for part of that time as well. That is not intended to be more than 30 days. And again, it includes the assessment and treatment planning portion that is as is a part of all of these. Now, if from that discharge, what is deemed clinically appropriate is something that is not yet a home setting, there are the CSM level 4 and CSM level 5, which are very similar with one distinctive difference, which is the presence or absence of 24-hour nursing. And so level 4 is up to 6 months of an observation stay with specific services at a host home or similar community type of facility that represents a lower level of care than a PRTF. Now that will have to get defined as it is contracted, but of note, and what is important here is that the member, him or herself, has to feel as though they've made progress through their own care journey. It cannot be just moving down the hall, right? It has to be something that feels like a community setting that shows that they have moved beyond the PRTF. There will be access as part of this to appropriate education, recreation, and social connection, and the full list of services as previously mentioned, including that initial planning and assessment, the leadership level care management by being high risk and high acuity enough to be a part of this model. There has to be that level of engagement from both the agency and the plan. There has to be that ad hoc respite support for the caregivers and the member, the family coordinator, again, the behavioral aid, the in-home capacity, and then as that relates to trauma and treatment capacity, in-home rehab, in-home substance abuse services, evidence-based intensive in-home services, in-home psychiatry, in-home nursing, but not necessarily 24 hours, and 24-hour crisis management. But this still includes the parent peer supports and the caregiver therapy, because the goal is that if someone had to end up at this more community-based setting, there's still an ability to transition them back up to the CSM home setting, or another model that I'll mention in just a moment that is unrelated to the community sustainability model, but the goal is to get them home. And as mentioned, the last piece is the same sort of license step down. This just includes 24-hour nursing. Same list of services, just with the addition of 24-hour nursing, because that is what is clinically appropriate for the member. So I have a case example to share a little bit more, although I know you've heard a few of those today. But this is representative of real experiences noted by our team in their casework. It is not a real person. It is a variety of real components, though, of what are real experiences that have been relayed. And I share that because this type of model is comprehensive, as is likely evident from this, but it also is unique. We would be one of, if the only state, to have this type of offering at this point in time. As all states are dealing with their issues in this space, this is a unique opportunity for us to lead and shine and show that we're taking this seriously and trying to put forward a little bit of innovative thinking that I think highlights a lot of the comments that were mentioned by all of the other presenters. So specifically here, I'm going to share about Crystal. So Crystal is 16. It's her third stay in a PRTF to treat her aggression, depression, and suicidal ideation. Her parents love and miss her, but they can't keep the family or themselves together when she's around. And her parents have said they're not going to pick her up from the PRTF this time. Crystal's parents had her young, and though they wanted better for her than their own childhoods, the traumatic patterns that they experienced themselves started to reemerge. While her parents decided to figure things out, they sent Crystal to live with her aunt and uncle from age 4 until 10, when her twin brothers were born. With 2 babies, her parents needed her help when they worked evenings. So Crystal was brought back. She'd never been an exceptional student, but now her grades fell to a place that caught people's attention. She was getting tough to manage in school, leading to conferences, meetings, in-school therapy, out-of-school therapy, but none of it seemed to make much of a difference. Crystal was guarded and angry, and one day that anger led to a knife in her hand pointed at herself and her mother, oscillating between the two of them as she screamed, cried, and threatened to kill them both. This led to a trip to the emergency department and then to a PRTF. She was there for 100 days. The discharge plan had the right pieces, but Crystal's parents struggled to keep it all together by themselves in a way that worked for them and for her. To Crystal, the therapist didn't get her. She had several in the year following the PRTF stay, and the diagnoses had begun to pile up. First, it was ADHD by her pediatrician when she was 10 and couldn't focus at school, then adjustment disorder, intermittent explosive disorder, and major depressive disorder from the PRTF. Now, her new psychiatrist diagnosed her with oppositional defiant disorder, since she was big enough to push other people around. And she met the DSM criteria for all of these diagnoses. At home, her parents were fighting constantly with her or each other, and her brothers weren't being cared for as they needed to be. DFACS became involved with the family, a case was opened, and Crystal ended up back at a PRTF. When her parents completed their case plan, they were reluctant to pick Crystal up from the PRTF the second time. And Crystal honestly didn't have an interest in being picked up or going home. She really hated it there. She lost interest in most things that would be part of a normal 15-year-old's life. But then, when she became interested in men, she met a much older man and started spending a lot of time with him away from her family. School was no longer in her life. Her parents were emotionally exhausted and at wit's end. They had nothing left to give, and they called the police, who picked her up from this guy's house, brought her home, where she was screamed at and hit. So she did what she thought was her last card to leave the family, and she threatened to kill the members of her family. DFACS, the courts, and every service provider one could imagine were now involved in the case. She was sent back to a PRTF, this time with the additional diagnoses of conduct disorder and post-traumatic stress disorder. Her parents were adamant that this time Crystal was going to stay at the PRTF until they had written guarantees from the facility that she was not a threat to anyone, and they knew that would be very, very hard to meet. What they didn't know, and that what no one knew, was that while Crystal had been staying with her aunt and uncle at a young age, she had also been sexually abused from age 4 until she left them at age 10. She'd been carrying that with her for 12 years. She was hanging by a thread and had nothing left to lose, and decided to finally confide in one of the therapists at the PRTF. With a lot of work on her part and the help of the trusted therapist, Crystal's mood began to change over several more months. She began to feel like she could live in her body without hating it or worrying that she was going to be attacked. She got to know herself a little more and even began to realize there were things she liked about herself. It then became time for her to transition out of the PRTF and start to experience a new life with her new sense of self. But there was no one coming to get Crystal. Her parents had abandoned engagement with her care. The bottom had fallen out from the family, and the PRTF called DFACS, who was familiar with the case. DFACS did not necessarily, in this case, want to take custody of Crystal because there was no clear path of where to place her. And Crystal wanted to be the sister that she couldn't be before. She was ready to embrace the community in the rest of her life, but her family wasn't ready for that given their traumatic history. And this is where this proposal starts to kick in. So what would be appropriate here would be the offerings related to that additional respite stay of up to 30 days in the PRTF, leading to offering number 4. Crystal's family can receive comprehensive assessment and treatment and discharge planning during that additional 30 days at the PRTF. Crystal can then transition into a setting where she can be supervised, housed, able to go to school, and receive additional trauma responsive services and medication management for up to 6 months. Also during those 6 months, the family would receive evidence-based trauma responsive services apart from Crystal in preparation for bringing her home. Both Crystal and the family would receive intensive in-home therapies such as multisystemic treatment and functional family treatment during those 6 months. And her family will receive care management assistance to build some of those coping and protective factors, increasing their community connection and building some more supports. There would be continuing care management, both for Crystal and the family, throughout this time and following this piece as well, given the ongoing nature of this relationship with the managed care plan. So the likelihood for success in this very complex case, and I appreciate the chance to share what many of our caseworkers, both at DCH and DFACS on a daily basis experience. And really, we see that this case looks like many others. It's our hope that it provides a stronger understanding of the importance for action and statewide coordination. So I share that as a sort of more initial sense, there are two other quick things I want to add just for context, based on where things stand with DCH today. The first is the rapid response process, which was co-created by DCH and the AMER group component of Georgia Families 360, and it relates to foster care, juvenile justice, and adoption assistance. The purpose here of this rapid response process is to expedite the movement of members that are at highest risk for negative outcomes, particularly those in non-therapeutic settings, through the appropriate levels and settings of care, and successfully bring them back into the community. Those are brought in based on a specific set of risk-related criteria, and there's a lot of daily high-quality supports from senior case managers. This is new, and that is one of the reasons to mention it to you all, that this has it has resulted in a 75 to 80% decrease in the target population that's being placed out of state since June. So while that is a short time frame, we know that it's allowing an improvement in the placements and in the outcomes, and it reduces the likelihood of some sort of adverse attachment trauma from that placement. We also know that there's a lot of really positive systematic improvements to the coordination efforts between the PRTFs, the CMOs, and DCH, as there's been necessary protocols to serve this population in this way. And it's really a blueprint for a broader rapid response process through Georgia Families, the base contract, as opposed to just operating in the 360 contract, which is now in development and including the key stakeholders across the board. And the last piece, which I know was mentioned in the prior presentation and other times, is just a brief update that we in Georgia are working on a therapeutic care model. It is different from therapeutic foster care by way of it being broader than just foster care. And there's a draft state plan amendment, and we are in regular dialogue with CMS so that we can get this up and running as quickly as possible. But just wanted to make sure that there was awareness. This is not foreign to us. We are deeply in the weeds with CMS to build this out and develop it for the benefit of the population. And of note, there is a strong connective point between the community sustainability model and the therapeutic care model. The therapeutic care model is more intensive than sort of what you would consider your lower acuity cases, but it is not as intensive as an inpatient stay. The level of acuity necessary in order to benefit from the therapeutic care model. So as an individual is working through their care journey and needing necessary supports, there are a number of family-related supports that apply in the therapeutic care model. And so that is the ideal placement on a sort of decreasing scale. And because this can be done in the home setting, right? This is just a different benefit package relevant to the needs of that individual. And it's just making sure we have the necessary structure to that benefit package in order to reimburse for that care. So all of these things obviously play together. We are working with all of the stakeholders and and we'll be working with the stakeholders. I will note the community sustainability model is going to likely be new to most folks here because it came about through conversations in the last legislative session from leadership from yourselves, and particularly a conversation with Chair Dempsey, and want to make sure that we related here first and now can begin the necessary stakeholder work to building that up to be as successful as we hope it can be. So I thank you on behalf of the department, and we are happy to answer any questions or go into greater detail.
Thank you, Mr. Portman. That's very exciting to hear. Good news. Yeah, I think we're in a new place. You just know who to talk to and ask the right questions. Maybe some things can really happen. This is really good news, and I hope we can help support that in any way possible. We do have a couple of questions. First, we'll start with Chairman Cooper.
Well, all I got to say is, wow. Thank you to Chairman Dempsey, because I know this is something she's worked on, and to you for leaving Washington. Trying to say it right. I'm from Texas. I say Washington. But anyway, and coming to Georgia to help us out. And of course, Joe, for always being there to a long time and knowing how it works. But I have some questions first, because it seems like you've done a lot of work for us. Okay, there are 5 components and all the CMOs have agreed to them. They have to agree to work within the 5, all of them? Basically.
They have agreed to do all 5. Yes.
Okay, so that you would have the movement between.
That's right.
All the ones. Okay, and you really think that we can, across the state, like since we're saying that these have to be a step down setting, can't be in the same hospital, have to be somewhere where they provide recreational activities and so forth. Do we have those? Do we have to?
So
What are they telling us that, I mean, across the state, that do we have that type of facility, or is this something that we have to build, or they have to build, or?
So our initial conversations and would be that it's a little bit of both. There are some facilities where that would exist, and there's some that would have to be contracted in a new way that are not traditionally contracted by Medicaid. But the difference between an in lieu of service and a state plan is that the entities being contracted by the plans can be new. They don't have to be those that are currently Medicaid enrolled providers.
Okay.
And so that is a new opportunity in order to bring more folks into the care fold.
Okay, I mean, that's great because it's so slow the other way of ever getting anything new. And did I hear earlier that this isn't for patients on Medicaid?
Correct. Within managed care specifically.
And within managed care. Did I hear that any young people are eligible for Medicaid if they have these kinds of issues? Or did I dream that? What about the ones that have private insurance?
So this model can only exist within the rules that are guided by Medicaid managed care. And so that is the only way that this specifically can be done today.
Okay.
But as we sort of, the goal is to build the evidence base that this is how this works. And this will actually lead to those improved outcomes. And then we can have a conversation, particularly within the fee-for-service side of Medicaid, or if commercial plans see the value and want to bring this forward on their own, they have the ability because now there's some evidence from this program to show the value.
Which has often happened in the past, is that they've sort of led the way. I mean, if these facilities are available and there's room, can the private insurance, will it be available to kids that their parents have private insurance? If they're paying private for it, or just the ones on Medicaid?
Specifically to this model, I would say there are no state guided requirements on the actual the provider that would be contracting with the plan in order to implement their portion of it. So to say to your point of what's the variation on the rooms, and couldn't a private plan participate? They could do so, but it wouldn't necessarily be guided by the policies that are directed through the contract on the Medicaid side.
With the Medicaid side. Well, what do we, if you've got it worked out, what do we have to do in changing the law to help you put this into existence, or we don't have to do anything?
I might be new here, but I'll say it might be one of these rare occasions where we actually say we have the legal footing to move forward on this as the law exists today. It's a matter of standing it up, making sure all the stakeholders are a part of the conversation, and giving us some time to build out and hopefully, and with work, succeed.
Well, it truly is really exciting. Thank you very much.
Representative Crawford.
Thank you, Madam Chair, and thank you for your testimony. One of the questions that I had, you touched on the new service, and that is the intensive parent peer supports service. Can you tell me a little bit more about that, one? And then in your example with Crystal, the parents would receive support apart from Crystal.
That's correct.
And how do we make sure that the services that they receive, though it's apart from Crystal, I guess they're kind of incorporated so that both are getting the care that they need. And then once they're done, everyone can live together?
Yeah, no, it's a totally fair question because it's a new type of service, and it would be it's a new service because under the existing regulations, you would have had to include Crystal as part of any of the services provided. She would have had to been present. And so because this is in lieu of a state plan benefit, we have that flexibility in order to operate a little differently, but the same case management from the managed care plan would be present, or not present, aware of both, coordinating all of those factors so that there's a clear understanding of what are the concerns that the parent needs addressed in order to feel comfortable. Are those similar to the therapeutic interventions being worked on for Crystal? How are we coordinating across those types of care? That would be pretty intrinsic to the nature of, and the reason why we feel strongly about making sure that there is that level of case management present, to the point that we want to make sure that we fund that level of case management present. And to the first point, parents peer supports is sort of a newer opportunity. There's Georgia's being the leader in peer supports within the youth population in particular. But when it comes to parents, because they are not the one receiving the Medicaid benefit, historically, they've never been able to receive any sort of benefit that would have been similar to this. And so this is opening up that opportunity to them to learn from other parents and there'll be pieces of this that are informed from stakeholders, from sister agencies, from some other state on the ground experiences. And a lot of that will be better defined by some of the specific contracts, but as a benefit, the goal is to make sure that the parents are receiving their own distinct care so that they don't have the anxiety that is almost always present in these questions of, do they have the capacity to bring a child home?
Yep, thanks.
Representative Cameron.
Thank you. Thank you for your testimony. Will the providers in question accept Medicare's payment as payment in full, or will families or anybody have a liability after? And will providers have to write things off? Or
so this would be a contracted rate between the plan and the provider. So the state would include, this is built in to our managed care rate.
Okay.
And so the state has done what is necessary in terms of our obligation, and that in terms of the payment side, the plans have to contract a rate that is good enough to actually get the provider to participate. But there should be no remaining liability for the individual receiving services or their family.
Thank you, Madam Chairman.
Thank you. Chairman Cooper.
Okay, I've got another one. Since it's often hard to tell which one came first, whether someone's addiction to drugs is because they have mental health problems, or they start on drugs and then they all of a sudden show they have signs of mental illness. Will this plan, if it's the drug use that is what gets them into the first part of treatment, so forth, will they be included in this plan?
They should be, yes. The drug use component, are you saying if there's drug use that is what's leading them into whether it's an emergency department or a placement into a PRTF, yes, that would be.
Alcoholism, kids.
Yeah, that would be an important part of that initial assessment that's been mentioned, the actual planning and assessment to know the underlying causes and the priorities for the individual and from the family. That would be something that would be known at that point in time and built into a care plan. That would be the vision.
Okay.
So
great.
Any other questions or comments? Well, I can't say thank you enough. Truly, I didn't have an inkling that this was about to happen right here, but I did enjoy speaking with y'all last year and putting out some creative ideas. And I just thank you for taking the ball and running with it. I think we're going to see sort of Medicaid lead the way for the way things to need to happen at all levels of care this time. And that's a thing that Georgia can be very proud of. Thank you. Thank you, Joe. Wow, we've had a good day. We need to go celebrate, I think, actually. There's some great opportunity after this first meeting. I think I've learned so much. I hope each of you have. Our next meeting is on the 30th of this month. So we'll come back together and be ready to roll up our sleeves and work some more. Excuse me. Chairman Cooper has something to say.
Well, I just want to sing some praises on Chairman Dempsey. I've watched Katie. She's quiet. I'm noisy as she goes about her work. And for years, I've heard her work on the issues regarding to our children, especially those with mental illness. And so it's when they said this, I'm punching her going, way to go, Katie. And so I think for the public and for those that work with us and other legislators to know that this is a major accomplishment. And as I often say, okay, Katie, when you're really, really old and you sit on your porch and you look back on your life and you decide whether you're happy with it or not, this ought to put you just in a sense of euphoria. So way to go. Thank you for letting me say.
Thank you. That's so kind. It's teamwork though, for sure. Lot of people, each of you that are here today and have told your stories, helped us learn more, helped us look at the creative ways we can start to tackle this. I think we're on the road. So thank you. I look forward to seeing you all again later this month.